we are going to see the musculoskeletal system pathology, where we shall start with non-tumoral diseases of the skeletal system, especially the bones. Then we shall see the tumors of the bone, shall see the diseases of the joint, the diseases of skeletal muscle, of course excluding tumors, neuromuscular junction diseases, and then we'll end with soft tissue tumors, where we shall see also the tumors of the skeletal muscle, smooth muscle, fibrous tissue, adipose tissue, and so on. So this is the content that we shall cover in this chapter. So the list of books, it is almost the same, except this WHO classification of the tumors of bone and the soft tissues, written 2 years ago. So as the introduction, you know how the bone forms. So you know that there is in a bone, we have a periosteum around the bone, but around the cartilage, you have a perichondrium and so on. And you know that where we have a cartilage, it gets also ossified, it becomes a bone, and again, there is another cartilage. So that's how bones, they grow, especially the long bones. That's how they grow. And as the long bones, they grow, also a person grows in height. So it depends on how the cartilage becomes ossified, and then another cartilage is formed, which will be also calcified, and so which will be ossified, and so on until someone reaches the maximum height that he or she has to get. So I think it is more explained here. So here on the left we have so on the left, we have here the bone, and then we have epiphysis, where we have epiphyseal ossification. So we have a cartilage which gets ossified when it becomes a stride, it becomes a bone. Again, there's another cartilage. So that's how we grow in length. So this is explaining how the membranous bone, the membrane bones or flat bones, they grow. So for the articular joint formation, so you know that a joint is between two bones, and for this to allow smooth movements between the two bones, to allow flexion or extension or abduction or adduction of the members or our limbs and so on. So we need this joint to be free. So we have ligaments, you have tendons around, and then here we have a joint, a space which has a fluid in small amounts, which allows the lubrication of the bones. And between these bones, also you have a disc. This disc helps to avoid a collision between the two bones. For example, when you jump and so on. So that's what we see here. So joint cavity, around it we have a menisci, they are like discs. So the through disc they exist between vertebra, but between other bones we have that meniscus. So for the bone metabolism, you know that there is a big role of osteoclast. So osteoclast, they resorb bone. So it is like to do renovation. Like when you have a house, you renovate it. So it renovates the bone by removing calcium, and then other cells will allow to bring a new calcium and the other proteins and so on. So, and you remember that we have seen that when our body needs higher titers of calcium in the bloodstream, there will be hormones which will be responsible for that. We know the roles of parathormone, calcitonin, and so on. And the osteoclast is the agent used by these hormones to make sure there is a resolution of the bone. And we have osteoblasts, which build the bone. So osteoclasts, we can say they destroy the bone, while the osteoblast, they buried bone. So the bone structure is that we have here in the center, here in the center here, we have an area without cells. Otherwise, we have cells around here. These are osteoblasts, which are around this osteoid. So they're the ones making sure this bone tissue increases in size by building it, while osteoclasts will come and destroy it when needed. So that was just a reminder, and there are other things I will not show in this presentation, but you will have them after we are done. You are done with the assignments, because there are things. If I show you, in that case, I would do. It would seem I have done your assignment. So there are some slides which are hidden here. I'm not sure, but you'll get them once you submit the assignment. So we start to see the diseases of our skeletal system, and we start with non-tumoral diseases. So as usual, you are familiar that we usually start with the malformations and things like that. So in here is the same. We start with these diseases. So the first one is achondroplasia. So I think you are familiar with this. A just means absence. Chondro is cartilage. Plasia is tissue and so on. So it is when there is a absence of or defects in the ossification of the cartilage. So there is impaired cartilage proliferation in the growth plate, and this, as you can understand, if you understood what I presented before, will be a cause of dwarfism, because if the cartilage doesn't proliferate, the bone will not grow in length, and therefore someone will not grow in height. So this is due to activating a mutation in fibroblast growth factor receptor 3, autosomal dominant. So the overexpression of this gene will inhibit the growth. And most mutations are sporadic and related to increase the paternal age. So you understand, if someone was born to a father who is old, so they have that risk of acquiring this achondroplasia. So these persons, they will have also mental problems, lifespan. Okay, here they say mental function and the lifespan and fertility will not be affected. So although they are short, they can give birth to children. So I think the symptoms are being explained here on the right, lower right, and we have a shortened bones, and we have for the flat bones, they have their defects, but this is less pronounced because when they are not well developed, you cannot see it physically. But these people, they will have large head size, frontal bossing, flattened nasal barge, a narrow foramen magnum, and so on. Spinal lordosis and varus. So in leg deformities. I think if you have seen these people who are very short, they usually have all these symptoms listed here. So this would mean that probably most of them, they are dwarf because of the achondroplasia. So clinical features then, they have short extremities with normal sized head and chest, and this is due to poor achondral bone formation. So the intramembranous bone formation is not affected in the head bones and so on. So here we are explaining the physiology, what we have seen before. So another condition is the osteogenesis imperfecta. So you can understand the bone formation is not perfect. I can just translate. So this is a congenital defect of bone formation resulting in structurally weak bones. So they have bones but which are very weak because for a bone to be strong, we need to have a good balance between a calcium deposit but also the fibrous tissue. So everything must be there because when you have too much calcium deposit, also it becomes a problem, as you shall see in some other diseases. And when you have a less calcium deposit, also it is a problem. We shall see some example of disease. So this disease is the most commonly due to autosomal dominant defect in collagen type 1 synthesis. So understand it, here it is an issue of fibers, collagen fibers. So the children, they will have they present with multiple fractures of the bone. And sometimes you can say maybe this child has been abused. Niba ari uruhinja nta babango yavunitse yasimbukaga ari uruhinja bazabatura hari ahantu bamuvunaguye, but they will be just spontaneous fractures. Kumwe umwana akina n'ibiki kubera ko akina muscles they contract and so on, and if a bone is not strong, it will be broken. So also these children, they have a problem in their sclera. You know, it is one of the membrane, the outer membrane of the eye. And they usually have also hearing loss because the bones of the middle ear they get fractured. So you can see on this X-ray, which has taken the whole body, that the bones here, they are not well formed. They are not straight as the other bones should be. They are bent. So, and probably the arrows are showing where the defects are, some fractures. Some of them may be asymptomatic because a small child will just cry. You will not know that there is a bone fracture until maybe you go to the hospital and then they examine and they find probably there are bone problems. So another condition is the osteopetrosis. So here, I can say it is when there is too much calcium deposit, if you can say so. So inherited defects of bone resorption resulting in abnormally thick, heavy bone that fractures easily. So nibyo navuga ko kugira calcium ni kimwe ariko kugira irenze nyinshi itajyanye nuko yagombye kuba ingana, itajyanye na fibers zihari, nabyo ubwabyo bigira bone vulnerable to be fractured. So they don't have a good function of the osteoclast. So bone resorption doesn't take place. So there will be always addition of calcium without resorption. So that will not make a bone strong. It will make it also weak. So mutation in gene mutation is responsible for calcium metabolism, chloride and chloride channels, and so on. So this is showing what happens. So there will be impaired osteoclastic bone resorption. So in summary, in some literature they call this stone bone. So it is a bone which looks like a stone. So on X-ray, it will be very opaque, very opaque. You see that it is as if there are no blood vessels, no fibers, and so on. So there will be generalized bone osteosclerosis and so on. So multiple fractures will happen, and there will be no union because when there is a fracture, our bones are made in a way that they will unite very easily, especially in younger people. In old people, it will be slow. Healing process is slow, as you know. But in young ones, this will happen. But for those affected with osteopetrosis, it will not happen. So clinical features include bone fractures, anemia, thrombocytopenia, and leukopenia with extramedullary hematopoiesis. This is due to the fact that the bone marrow, where the bone marrow, it is where the hematopoiesis takes place, also will be ossified, or will be calcified. So if there is calcium deposit in the marrow tissue, hematopoiesis will not take place. And that explains why these people they have anemia, thrombocytopenia, and leukopenia. Anemia so just refers to low red blood cells numbers and hemoglobin, of course. Thrombocytopenia, understand less platelets, and leukopenia less white blood cells. So because our body usually it has a way to cope with these challenges, it will make hematopoiesis outside the bones. So this is what we call extramedullary hematopoiesis. So hari abantu benshi uzasanga bakora bo ntabwo ari benshi ariko barahari iyo bafite ibibazo muri bones zabo bakora hematopoiesis ugasanga iri gukorerwa cyane cyane mu mwijima cyangwa se irakorerwa muri spleen and so on. This is extramedullary hematopoiesis. So this is an X-ray. Nyirango niba mwarajyanyije cyangwa mwibuka izi X-ray twagiye tubona. Here you see that it is completely white. Ugereranyije n'izindi twagiye tubona. This is because every bone here is completely calcified. There are no medullary tissue. The medullary tissue or where we have hematopoiesis in the bone marrow, usually you find it is less dense. It is radiolucent because it contains the fat and just cells without the calcium. But here you see that everything is white, opaque. And you remember that especially in adults, the hematopoiesis takes place especially in the iliac bone. And the iliac bone, here you see that it is completely opaque. So these patients can have vision and hearing impairment due to impingement of the cranial nerves, hydrocephalus due to the narrowing of the foramen magnum, renal tubular acidosis seen with carbonic anhydrase 2 mutation. So the lack of carbonic anhydrase results in a decreased tubular resolution of the bicarbonates, leading to metabolic acidosis. So usually these patients, to survive, they will need the bone marrow transplantation. So it means they need to get new hematopoietic stem cells for them to make new blood cells. Of course, here it will be just a mechanism to correct anemia, thrombocytopenia, and leukopenia. It will not be a mechanism or a treatment to deal with osteopetrosis itself. But here, in a way, because osteoclasts are derived from monocytes, when you give someone these hematopoietic stem cells, which can give rise to monocytes, you can also boost the differentiation of the osteoclasts. So another disease is rickets and the osteomalacia. So this is the opposite to the osteopetrosis. So rickets and the osteomalacia, there is defective mineralization of the osteoid. So it means there is less calcium in the bones. So osteoblasts normally produce osteoid, which is then mineralized with calcium and phosphate to form bone. So, but when there are low levels of vitamin D, there will be low serum calcium and phosphate. And then, you know that vitamin D is normally derived from the skin upon exposure to sun, right? So, you know, skin here, it refers to the, we have this cholesterol under the skin. They're the ones which, when they are exposed to the ultraviolet light, will give rise to the precursor of the vitamin D. So most of our vitamin D is derived from that cholesterol in the skin. The other one is coming from the diet, what we eat. So activation requires this hydroxylation by the liver, followed by alpha hydroxylation by the proximal tubule cells of the kidney. So you will understand that someone having also renal problems, they will have automatically problems of vitamin D. So active vitamin D raises serum calcium and phosphate by acting on intestines. Here, with increasing absorption of calcium and phosphate at the kidney level, vitamin D will make sure there is increased reabsorption of calcium and phosphate, and in the bones, vitamin D will increase the resorption of calcium and phosphate. So vitamin D deficiency is seen with decreased sun exposure, especially those that are living in northern latitudes. So abatuye mu bihugu nka Sweden, Norvege, Finland, aho ngaho bakunda kugira. So that's why iyo uba hariya mu gihe cy'ubukonje, guhera mu kwezi kwa 10 kugera mu kwezi kwa 3, nta zuba uba ubona practically nta zuba riba hejuru. So aho ngaho bafata imiti, iyo uhari ufata ibinini biba biri ahantu muri supermarket, ntabwo ari ngombwa muri farumasi. No muri supermarket biba bihari ku buryo almost every day you take one pill. So there are other conditions leading to that. So icyo izi ndwara zitandukanye rickets na osteomalacia nuko rickets ifata abana, osteomalacia ikavuga ku bantu bakuru. Baba kukiba bitandukanye nuko bya byose iyo umwana afashwe kubera ko aba akeneye gukura mu burebure, his or her bones need to grow. There are consequences which are different from those in adults. So rickets is due to low vitamin D in children, resulting in abnormal bone mineralization. So most commonly arises in children less than 1 year of age. So they present what we call breast deformity, which just is inward bending of the ribs with anterior protrusion of the sternum. Ngo ibintu byumvikana, imbavu zisa naho ziteberamo imbere, noneho ahubwo sternum akaba ari iturumbuka kazi. They have a frontal bossing enlarged forehead due to osteoid deposition in the skull. Rachitic rosary due to osteoid deposition at the costochondral junction. And have a bowing of the legs, may be seen in ambulating children, as you can see on this chart here. So osteomalacia is in adults, as I was saying, there is inadequate mineralization, which results in weak bone with an increased risk for fractures. So you can see here in a normal bone, so this is a drawing, of course. In a normal bone, you can see that the bone here is so it is solid. But on the osteomalacia, you can see that there are some channels. So ahantu hari kuba calcium akaba twakwita ko hari vide. So this is a representation, of course. So, and this can explain why these bones are easily fractured. So laboratory findings include the low serum calcium, low serum phosphate, increased PTH. So parathormone is increased, and alpha alkaline phosphatase. And this PTH is increased why you know its function. So the body is trying to make sure the bonds are resolved to increase the serum in the calcium in the serum. So the signs and the symptoms, the patient will have painful bones and joint, muscle pain and weakness, difficulty in walking, and the muscle cramps. This is, of course, when that patient doesn't have yet fractures, because when there is a fracture, it is a severe pain and impotence and so on. So osteoporosis is the reduction in trabecular bone mass, results in a porous bone with an increased risk of fracture. So the risk of osteoporosis is based on a peak bone mass attained in adulthood and the layer of bone loss that follows thereafter. So icyo nshaka kuvuga ni ikibazo kiri ahangaha nuko ntabwo bijyana cyane no gutakaza wenda calcium n'ibindi, ahubwo hari aje ugeraho ukaba wagumye kugira bones zikomeye zujuje navuga ubuziranenge, kuko nyuma yaho nkuko muzabona muri literature n'ikibazo cya osteoporosis, ntabwo umaze kugira imyaka 40 cyangwa irengaho wavuga ngo ngiye gufata vitamin D ihagije ngo ku buryo ntazagira osteoporosis. Niba utarayigize muri icyo gihe, kugeza icyo gihe ntacyo biba bikikumariye. So niyo mpamvu hano bavuga ko ikibazo si uko hari ikintu bone zitakaza, ahubwo ni ukuba zitaragize ibyo zigomba kuba zikeneye mu gihe gikwiriye. So you see that at around 30 years, it is when you should have the peak bone mass. And it is based on genetics, vitamin D receptor variants, diet, exercise, and so on. So after that, about less than 1% of the bone mass is lost each year. Mva nyuma y'imyaka 30 cyangwa 40 bitewe n'umuntu nk'uko izi factors ziranze byerekana. Bones zigenda zigabanuka. Mpamvu uzabona umuntu yari afite imyaka 30 ari umusore cyangwa yari umudamu munini muremure and so on, ariko imyaka 50 ukabona yabaye muto, ari mugufi, ukagira ngo wenda ni relative, nuko ni relative wenda ntubyite, ariko it is a reality. So nyango hari diagram naboneka niba nawe nayishyizemo, ariko igaragaza umuntu uko akura akagera iyo myaka 30-40 nyuma y'upima uburebure bwe bugenda bugabanuka. So niyo mpamvu uzasanga, reka turebe nk'umuntu umwe uzwi cyane wari umwamikazi w'Ubwongereza, ngira ngo muzamubona mu mafilimi, ari umudamu muremure, umukobwa muremure, ariko muzi uko yatanze areshya. So ni mutanze urugero ko ari umuntu uzwi n'abantu benshi, kandi ushobora kubona amafoto ye mu gihe byose kuva ari inkumi kugeza ashaje. So yagiye aba mugufi. So iriya ni realite rero, ntabwo aba ari ukubeshya ngo nawe ngo uriya muntu ko yabaye mugufi, ngo nuko ari relativism. It is scientifically explained. So for bone mass is lost more quickly with lack of weight bearing exercises. So niyo mpamvu gukora exercise nabyo bifite akamaro. Uko udakoresha bones zawe, wenda ukoresha ingufu, nyuma y'ingufu cyangwa ukora physical exercises, niko ziba resolved very quickly. Niyo mpamvu uzasanga ari abantu babiri banganya imyaka, babaye wenda n'ubuzima bumwe, imirire imwe, ariko umwe kubera ko adakora siporo cyangwa adakora imirimo y'ingufu, azasanga arwaye osteoporosis, undi ntabwo ayirwaye. So other reasons for losing too much of the bone mass is the poor diet and less estrogen. So that's why women in menopause phase, they develop osteoporosis than in the younger ones. So there are genetics. These are like factors. So genetics, Caucasian or Asians, they are the ones which are more affected by osteoporosis. Ahari byanasobanurwa nuko batuye abenshi mu bihugu bikonje cyangwa bitabona izuba mu buryo buhagije. There may be a reason. There is, so female, of course, family history. If someone has had the osteoporosis in a family, so it is most likely that in that family there will be others who will develop it. So it increases with age, as I was explaining. So post-menopausal phase, advanced age, low testosterone in men also. Is the risk factor, like in women, low estrogen, decreased calcitonin, and so on. So nutrition, low calcium intake, low vitamin D intake, high phosphate intake. Ngira ngo murabyibuka twabonye muri kidney ko cyane kidney akazikora gishaka ko calcium yiyongera, it excludes phosphates, kubera ko iyo phosphates zibaye nyinshi, calcium nayo iri zikagabanuka. So inadequate calories, physical exercise, I have explained this. Sedentary lifestyle, it is a risk. Lack of weight bearing exercises, low weight and body mass index. So nubwo kugira high body mass index atari byiza, ariko biragaragara ko noneho umuntu unanutse, ubusanzwe wabayeho ari thin, ari lean, n'ubundi aba afite risk yo kuzagira osteoporosis kurusha abandi. Others are related to lifestyle choices. Abantu bafata caffeine, cyane alcohol, abanywa itabi, lack of exposure to sunlight, byose bihita biza nawe kuri Caucasian and so on. So medications, abantu bafashe corticosteroids, anti-seizures medication, so abafite indwara ivura igicuri and so on. Heparin, thyroid hormone and so on. So comorbidity, abantu bafite anorexia nervosa, there is this, those who don't want to eat, so they psychologically they induce the loss of appetite and so on. So here so each of these factors there is an explanation on how this will lead to osteoporosis. So the most common forms of osteoporosis are senile and post-menopause. So it is very rare to see osteoporosis before before 50 years of age. So of course you can ask, how can we differentiate this from osteomalacia? So you will need to combine investigations, laboratory investigations, X-rays, history, and so you will have to combine these ones. So otherwise, if you have an X-ray itself alone, you cannot distinguish both, because in both we have less of calcium of bone calcification. So this is what I was explaining. Do you see this one? After 10 years after menopause, you see her height, how it was. Then if after 5 years, you see how she is. If 25 years, you see how she is. So kuba ari mugufi bigirwa muri ane bintu byinshi, harimo za lordoze n'ibiki, umugongo wihina cyane, nabyo ni kimwe muri byo, ariko usibye n'ibyo n'ubundi na density ya bones igenda igabanuka ku buryo n'ubundi aba mugufi nubwo atajya lordoze, ubugufi bugenda buza. So clinical features: bone pain and fractures in weight-bearing areas such as the vertebrae. So that's why they lose height and then they develop kyphosis. Other areas which are affected are hip and distal radius. So the bone density is measured using a DEXA scan, the machine in nuclear medicine and so on. So serum calcium phosphate, PTH, and alkanophosphatase are normal. Labs help to exclude osteomalacia. This is what I was saying. We have seen that calcium, phosphate, PTH, and alkanophosphatase, they are calcium and phosphate, they are decreased, while PTH and alkanophosphatase are increased on the osteomalacia. But in osteoporosis, you see that they are normal. So that's why I say the X-ray will not help you to distinguish these two unless you combine with clinical information, history, and laboratory tests. So as here to this, osteomalacia has the similar clinical presentation as the osteoporosis. So treatment will to do exercises. So n'abantu akenshi uzohereza muri kinesitherapy cyangwa physiotherapy kugira ngo bafashe gutangira gukora exercises at least nubwo osteoporosis itashiraho burundu, bifite ikintu cyabafasha bibafashamo. So vitamin D and calcium, this they limit the bone loss. Others are bisphosphonates, which induce apoptosis of the osteoclast. Estrogen replacement therapy. Hano baravuga ko it is currently not recommended. This is because, as you remember, external or extrinsic estrogen taken by someone, it increases the risk of developing the breast cancer. So probably that's why it is not recommended to use it nowadays. Ariko muzabona abadamu benshi bagira ibintu bimwe bita rubagimpande bari muri menopause, aribwa ingingo, akenshi no osteoporosis zabitera ubundi bakunda kubaha estrogen. Ibinini nk'ibi ngibi baha abantu baringaniza imbyaro kugira ngo agire estrogen, noneho izi sinye zigabana. So the Paget disease of bone, you remember that I mentioned that there are 3 kinds of Paget disease. The first one we saw it affects the vulva. The second one we saw it affects the breast, and the third one it affects the bone. So I had mentioned that. So for the bone and the vagina, the Paget disease is a precancer lesion, but here it has nothing to do with cancer in the bone. So the issue here is the imbalance between osteoclast and the osteoblast function. And this disease is usually seen in older people. Etiology is not known. Some people, they think it is viral. So I now check more viruses nka paramyxovirus, I now check itera iseru, measles virus, and so on. Someone knocking, making a noise there. Okay, so the etiology is not known. So the localized process involving one or more bones does not involve the entire skeleton. So Paget disease doesn't affect many bones, it affects usually one. So there are stages osteoclastic, you understand. If the phase is osteoclastic, there will be too much bone resorption. Then the mixed osteoclastic, meaning both osteoblast and osteoclast are working very hard. And the third one is osteoblastic. So if bivuga ko ukoreye umuntu x-ray ushobora kubimenya. Osteoclastic azaba afite bone resolution nini cyane. Mbese ushobora kugira ngo ni igufa ryafashwe na osteoporosis. Ariko nusanga ari rimwe ubwo ntabwo ari osteoporosis, kwa kwifata many bones at the same time. And you will, if it is on osteoblastic phase, you will find that it has more of fibrosis and so on. So, end result is a thick sclerotic bone that fractures easily. Biopsy reveals a mosaic pattern of lamellar bone. Mosaic pattern, so hari uduce tumwe turi resolved, harimo vide, ahandi it is completely just calcified without even osteocytes or osteoblasts and so on. So here, the diagram is explaining that there are predisposing factors, gene, meaning mutations in these genes listed here. And we have also environmental factors such as viruses, pollution by pesticides. So abantu bakora mu mirima batera mu mirima iriya miti they are exposed. Calcium and or vitamin D deficiency, metal exposures, so on. So local factors, they are biomechanical stress, increased blood flow, and so on. So Paget disease of bone regions then will be manifested as it is being shown here. So clinical features then, there are bone pain due to microfractures, increasing heart size. Skull is commonly affected. So now bavuga heart size. The skull is more affected. So hearing loss because of impingement of the cranial nerve. You remember this also, we saw it in other diseases affecting the bone. Lion-like faces, involvement of craniofacial bones. Isolated elevated alkaline phosphatase, saying that it is isolated means it is not accompanied by increase in vitamin D or calcium and so on. So in the osteolytic phase, you can see how the bone will be in osteolytic phase. So we have too much osteoclast, and you see that the compact bone here is decreased. It's as if the whole bone is having the sponge bone, as you can see. So, and in the osteosclerotic phase, you can see that everything here is fibrous, and even the spongy bone here is decreased. And we have the mixed phase where we can have both osteoclastic and osteoblastic phase. So a fracture can happen anywhere, be it at the osteosclerotic area or at the osteolytic area also, it can be fractured. So the treatment will include to administer calcitonin, which will inhibit osteoclast function. Also to give biphosphonates, which induces apoptosis of the osteoclasts. So I think I did this treatment, the biphosphonates. We have seen it also in the previous disease. So calcitonin is indicated just in this target disease of the bone. So the complications will include the high output cardiac failure due to formation of the arteriovenous shunts in the bones. And another complication is osteosarcoma, which is a cancer of the bone. So you can understand, because there is a high turnover, bone destruction, bone formation, bone destruction, bone formation. This means that osteoblasts will work very hard. And osteoblasts, if they work hard, they also multiply very easily. By multiplying themselves quickly, there are limitations and so on, which will induce now the formation of the cancer osteosarcoma. So we shall come back to this osteosarcoma afterwards. So normal tibia is shown here, and the target disease of the tibia here. You can see that here there are areas which are very whitish or radio opaque, but other areas here they are radiolucent. So meaning that the lower part of this bone seems to be at the osteoclastic phase, while the upper part is on osteosclerotic phase. So so as you saw, we started with malformations or congenital anomalies of the bones. We continued with metabolic diseases of the bones. So now we go to the infection or inflammation. So osteomyelitis. So hari osteitis when there is just inflammation of the bone. But when they add the myelitis, it means also the bone marrow is affected. So infection of the marrow of the bone, usually it is seen in children. Iyi ni indwara yiganje cyane, ahari izagabanuka uko leta y'u Rwanda ihangana na malnutrition. Kubera ko personally nabonye bayifite abana bafite osteomyelitis n'abafite malnutrition. Cyangwa se abantu bafite ikibazo cya sickle cell disease, nabo bakunze kugira osteomyelitis. So it is usually caused by bacteria, Staphylococcus aureus, and so on. And it rises via hematogenous spread. So this patient will have a transient bacteremia, meaning you can isolate bacteria within the serum or bloodstream. And then this bacteria will go to the metaphysis of the bones. Ko murabizi ko niho haza amaraso menshi niho atangira aza ayagiye kuri bones. Nicyo gice ifari kuriramo. Open wound bacteremia in adults seeds epiphysis. So aha ku bakuru epiphysis nizo zifatwa cyane kandi bo iyo bagize osteomyelitis akenshi ni infection iba yaje iturutse kuri trauma. Henda yakomeretse injamo bacteria ntiyavurwa ntiyagirwa disinfection and so on, cyangwa se wamuvuye nabi wenda uri gukora procedure muri joint itari aseptic and so on. So there will be bone pain with systemic signs of infection such as fever, leukocytosis, C-reactive protein, and so on. So erythric focus na hari abscess kubera ko ubundi haba hari kuvamo pasi amashyira surrounded by sclerosis of the bone on X-ray. So the erythric focus is called sequestrum, and the sclerosis is called involucrum. So these are the terms you must say. You must say no. Sequestrum zabibona iyo bari kubaga abantu bafite osteomyelitis baravuga ati haracyarimo izindi sequestrum. So no kuvuga bone iba yaracagaguritse hakagira ibice bya bone biba birimo aho ngaho gusa bivanze na pasi. So nkuko twabize no muri healing and repair n'ibindi uko mwabize, ntabwo umuvuye ukagira ibyo bice bya sequestrum usigamo ntabwo n'undi azakira. hazakira. So mu kumubaga rero uba ugomba kumenya bashobora ku pass and the sequestral all of them they have been removed. So diagnosis is made by blood culture ariko ntabwo diagnosis of osteomyelitis itself because ni clinically urabibona ahubwo icyaha bashaka kuvuga ni ukumenya bacteria yabiteye no kugira ngo umenye ni uwuhe muti uzamura. So akenshi uzasanga afitemo iyo pass ishaka inzira ngo yisohokere hanze, niyo mpamvu azaba afite pass isohoka hanze. So hazabamo fistulization of that osteomyelitis to the skin. Iyo pass izaba isohoka yisohora hanze. Risk yawe ihari nkuko byanditse hasi nuko aho hantu hari fistula izana pass, hari risk nyinshi ko hazagira squamous carcinoma of the skin. So these are bones. Can I say these are normal bones on the left? On the right side, you can see that there are areas which are radiolucent. Radiolucent area. Ubona ko havangavanzemo uduce duto cyane turi radio opaque. Tuni ko batangira guteka tiso bishobora kuba ari sequestral. So aha ni igihe umuntu ataragira fistulization to the skin. Very clear. So the most common causes include Staphylococcus aureus, as I said, and Neisseria gonorrhoeae in active young adults, Salmonella in sickle cell disease, one of the sickle cell disease. Others are Pseudomonas for those who are affected by diabetes and those who are intravenous drug abusers. We have other bacteria such as Pasteurella and Mycobacterium tuberculosis, which usually affects the vertebrae, which is Pott's disease. Pott's disease is tuberculosis, you have muri vertebrae. So, ahari wenda nubwo navuze ko ifata abantu bari malnourished, ariko hari nubwo bituruka ku gatroma gato kumwe abana bakina, akagira akantu kamujomba, agasebe ntikavurwe kaba ari gato. So bacteria zikagenda zikazagera kuri bone. So I remember when I was in Doc 4. So I had a friend. Then we went to his family here in Kigali, and then I'm going to so because I knew I was a finalist medical student. So when was the kukaguru, I tataka cyane. And so I said probably this child is having an inflammation in the bone. So babwira ko bajya kwa muganga, so I directed them where to go. Baratindaho gato mu gihe batinze yatangiye kugira fistulization, so baramubaza. So ikindi kibaho nuko uyu nta ufite osteomyelitis ntabwo abagwa rimwe, abagwa inshuro nyinshi, ko akenshi nubwo ukora uko ushoboye ngo umaremo sequester and pass, it doesn't happen. Buri ryagira ntihabura ibintu bisigara ukazasubiramo, cyangwa se ya bacteria zasigaye wenda pass bayimazemo ariko bakagira nke zisigara, then n'abantu babagwa kenshi. So I remember at Sashibe when we are in Doc 2, hari abana babaga maze nk'imyaka 3 abagwa bakategereza. So I remember hari wari ufite ikibazo cya tibia yarafashwe nk'uko byerekana hano, yarangiritse ku buryo bukomeye, ku buryo mu kumubaga bisa naho yose bayimaze. So mu kuyimaramo bagiye bafata igice cya fibula akaba ari cyo cyangwa perone mu gifaransa, akaba ari cyo batera hariya, bagategereza ko kizakura bigaterana bakongera bakabaga, so bitwara imyaka myinshi. Kubera ko fibula yego ifite akamaro, ko tibia niyo ifite akamaro kanini, niyo it is a mass bearing bone. So of course na fibula ntabwo kwa kwikura n'umwana irakura nayo yarakuze, ariko byari bikenewe ko agira tibia kuko indi yari yarangiritse ku buryo bukomeye. So surgery ikorwa muri phases nyinshi, ntabwo ari ikintu ukora rimwe cyangwa kabiri ngo umwana ngo aratashye, ushobora gutaha ariko azagaruka n'ubona akongera akabaho. Ariko ko akenshi aba ari umuntu ukenera desinfection itakorerwa mu rugo, aguma aho ngaho abanaseze bamukorera nursing kugira ngo infection izashiremo. So another condition is called avascular or aseptic necrosis. It means means there's a necrosis of the bone, but without infection, but because of the problem of vascularization. So ibi bikunda kuba muri rusange kuri head of the femur bone, n'abaga muzajya mubabona aho usanga hano I think this is the head of the femur, of course, in this picture. Aho ubona yarabaye fragmented, umuntu akaza aribwa mu itako, but singishobora gukandagira, na movement ziranga, wakora x-ray ukabona hano ko it is irregular. Right, it is irregular because there has been ischemia and then necrosis. And then the cartilage becomes fragmented, na bone ukabona kanje kuba fragmented. Ariko ukasanga muri history ugasanga nta kintu yabaye, nta trauma yindi. So this is just a septic or a vascular necrosis. Vessels zajyanaga amaraso ariya zagize ikibazo, ntabwo amaraso yarakigera. So the causes may include trauma or fracture, most common steroids, sickle cell anemia, and Caisson disease. So Caisson disease ngira ngo murabibuka muri hemodynamic changes ni igihe hari gaze yinjiye muri blood vessel, nk'igihe muri gutanga perfusion. Perfusion yashiramo ntimufunga, ahubwo na air bubbles zikinira mu maraso aziragenda zifunge somewhere, ibe nka embolism. So if it affects then like a long bone, that bone will not get blood. So that condition is called the Caisson disease. So the complications will be fractures and so on. The osteoarthritis, what I was explaining. So clubbing is not a disease, it is a sign of some other diseases. There will be hypertrophic, it is called also hypertrophic osteoarthropathy. Soft tissues and periosteal bones are the one being hypertrophied. So akenshi rero bigaragara ku muntu urwaye indwara ituma atabona oxygen ihagije mu maraso. So no bakunda ko hari abantu bafite ibibazo by'umutima, ibibazo zimwe twabonye chronic obstructive pulmonary diseases, babandi bakunda kugira ibingibi clubbing. So iyo ubona umurwayi ameze gutya rero uzashakira ngo either cardiac problem or pulmonary problem ituma atagira oxygen ihagije, no bakunze kubigira emphysema, lung cancer, heart defects. So clubbing is not a disease, it is a sign of these diseases. So here we end with fractures. So I don't think we have to say many things here. So fracture, it can be traumatic, or it can be ari traumatic, ari pathologic. Iyo bavuze pathologic fracture ni igihe umuntu ize fracture kako bone yari isanganywe ikibazo runaka. Wenda yari asanganywe osteoporosis, yari asanganywe metastatic cancer to the bone and so on. Cyangwa ya Paget disease of the bone, aneurysm bone cyst n'ibindi. Ibyo ngibyo yabisanganywe none akagira fracture, ibyo babita pathological fracture. So ashobora no kuba ya metastatic cancer ahubwo na cancer iba ariyo cancer which is primary in the bone. So as a consequence, of course, fracture it causes too much pain. It is very painful. So usually hari uburyo muzabyiga muri orthopedics cyangwa mwarabyize bavura fractures kimwe no kuvura relaxation cyangwa igihe joint igufa ryicomoyemo muri joint. Uburyo bivurwa icyambere nuko iyo adafiteho igisebe ku ruhu, icyo gihe tubita ko ari closed fracture. Icyo gihe ushobora kumuvura ku buryo muri conservative, ushobora kumushyiraho cut cyangwa sima cyangwa plâtre mu Gifaransa, iriya sima bashyiraho y'umweru, that's for immobilization. Ariko ya plâtre ntabwo upfa kuyishyira, uyishyiraho wabonye neza ko the bone fragments are well aligned. Uba ukora icyo bita reduction, uko yabayo fracture kenshi iki gice cya bone ntabwo kiguma ahubwo kiraza kigasa n'ikinyuranamo n'iki. So icyo ugomba gukora under anesthesia ni ukora ku buryo iki gice kigarura kikarebana n'iki, ku buryo bizaterana mu buryo bukwiriye kandi bitagoramye gutya. So iyo ni reduction. reduction byanditse aha ngaha. So iyo ubonye umaze kuyikora neza uhita ushyiraho sima ikuma, noneho icyo gihe umurwayi ashobora no gutaha akazaheza muri control kureba uko bimeze. So iyo afiteho igisebe, icyo gihe tuhita ko ari open fracture. Iba ifite risque ko ka gasebe kazinjiramo infection ikajya muri ya bone yayirangiza fracture, noneho akaba yazibona osteomyelitis. So that's why it is contraindicated kumushyiraho plâtre uwo nguwo, cyangwa se kumubwira ngo natahe ngo ategereze ngo dufite abarwayi benshi. This is sensitive. I remember like 1 year ago, about 1 year ago, so kama dukoresha ibizami sashi kandi gukoresha exam post graduate, noneho uhura n'umudamu muri koridoro z'ibitaro ngo hafi y'aho binjira mu bitaro hari, ahita ampamagara ngo nimutabare ngo ntabara afite ikibazo. So yari afite umugabo wagize fracture mu kuguru iriho n'igisebe, ajya kuri district hospital bashyiraho sima, which is itself a problem. No babona ntacyo biri gutanga bamweza CHK. So ahageze CHK naho ko ari abanasezi babakira bakabaha rendezvous n'ibindi, umunasi amuha rendezvous ya nyuma y'amezi nk'abiri. Umugabo yari yicaye kuri moto adashobora no kuyiva, nawe yaramenya reka impapuro na transfer. Okay, so ko ni ukoresha ibizamini yagenda bitari ndwanaho nta kundi nabigira. So ntabwo nari muzi, so ndagenda kuri outpatient, so mbaza umunasi kwereka umurwayi musubizayo ngo none ko dufite abarwayi abana, ariko yewe uko nize nta muntu ufite open fracture ujyanwa mu rugo cyangwa waharande biyama, kuko imfa rye rizagiramo infection, uzabigenza bazamuca ukuguru uzabyirengera. Jewe uko nize nuko open fracture it is an emergency, ntabwo ahabwa rendezvous, ahubwo no kubagwa yabaguye umunsi. So umunasi atangira kuvuga ngo urumva ngo njyewe ntibabasobanurire, ntabwo bagusobanurire kandi ubisoma byanditse muri transfer. So bahita bamushyira kuri gahunda y'ako kanya yo kumuvura. So when there is a fracture, make sure there is no wound. If there is a wound, it is an open fracture. It should be treated as an emergency. Ntabwo icyo gihe uzashyira ibya cast, ahubwo niba uzasanga bamubaga bashyiremo ibyuma biri byo bifatanya bya bice. Ibyuma biba binagaragara murabibona mugiye kubita. So mu gihe when it is a closed fracture, you can put the DC cast. So this is in normal in general how things are done. So I think here pathological fracture na ngibirana sano ibaho igihe umuntu afite osteoporosis, multiple myeloma. Multiple myeloma, it is a cancer arising from plasma cells and it usually affects bones. Cyane cyane nuko yakwiva muri itangira muri bone marrow, that's why it affects bone. So osteogenic sarcoma ni kimwe na osteosarcoma. Metabolic diseases za rickets n'ibindi byose nabyo yabifite, akagira fracture tuyita ko ari pathological fracture. So here we have the classification of fractures: avulsion, overreading, comminuted in ya fracture yaba ariko has many fragments kaya ngo bayiseye. So this is of course a difficult kuyivura kubera ko icyambere ngo ugiye kumubaga ntabwo uca uzabufata, kuko kumubaga ufite intention yo gufata ibice byatandukanye ukabiteramo ibyuma bigafatana. So ntabwo rero iri comminuted wabikora ngo bishoboke. Icyo gihe ushobora gukoresha ubundi buryo. Hari oblique, transverse, green stick ni igiti kibisi, iyo giciyemo ntabwo gihita gitandukanye. So harimo fracture ariko bone fragments zatandukanye. So rero ntabwo wayirekera kugira ngo nuko zitatandukanye, ugomba kuyigorora and spiral and so on. So it can be distal, middle, proximal, just around the epiphysis, around the diaphysis and so on. Or this, they have consequences. Bitewe n'aho fracture abereye, hari ubwo ashobora kuvurwa cyangwa se ntavurwa, hari ubwo ashobora kubagwa cyangwa ntabagwa. So kuvurwa wari wese arakora, kubagwa cyangwa ntabagwa bitewe n'aho iyi fracture yabereye. So usually, when you suspect anything here, what you have to do is to do X-ray. Kwari igihe ukeka ngo umuntu afite fracture ugasanga wenda yes ni fracture ugasanga yabaye comminuted, icyo gihe uzamenya ngo surgery will be delayed. Surgery will be delayed kubera iki? Icyo gihe uzakenera ko tudufragma tubanza kwiteranya tugasa naho tukoze bone imwe. Akenshi bibaho nta n'indi surgery ukora, ahubwo iyo ugize amahirwe cyangwa uzagize amahirwe bigafatana byose urekera. Icyo ugomba gukora iki ni reduction kugira ngo consolidation itazaba bone iri muri abnormal position. So that's all for non-tumoral diseases of the bone. If you have questions, you can ask them before we proceed. Any question? Ngo hano hari agashushanyo kerekana umuntu agenda kuri bekiye cyangwa imbago. So ni ukubera ko niba ushyizeho cast cyangwa ari immobilized ukoresheje n'ibyuma cyane abantu bagize open fracture, ntabwo uko kuguru ntabwo bagomba kugukoresha ibintu byinshi ngo kugendereho emisoni. So niyo bagomba kugenda mu mbago igihe runaka. So bone tumors, we start with osteoma. As you see, it is a benign tumor arising from the bone. So it is a benign tumor of bone. Most commonly arises from the surface of fascial bones. Yango murabona ko ari skull bone, ariko hari akantu kari ku mpanga hano gatoya bari kwerekana mo hano. So that is osteoma. Ariko hanga murabona ko yo ayifite mu rutoki rumwe runini, hanyuma X-ray bayigaragaje. Associated with Gardner syndrome. Gardner syndrome ni abantu bagira amapolype, ni indi syndrome igaragaza abantu bagira polyps nyinshi muri colon. So ariko bakaba banafite n'ibibazo bya bones. So bivuga ko ubonye umuntu afite osteoma, umuganga uba ari umuganga mwiza kandi umuntu afite osteoma, you must make sure also you send that patient to an gastroenterologist in internal medicine. Niba ari umuntu mukuru kwanga barebe ko adafite na polyps. So osteoma ni osteoma but which forms too much osteoid. Osteoid twabonye ko ikorwa na osteoblasts. So osteoblasts zikora osteoid. Osteoid rero ni za fibers, collagen fibers there. Occurs in young adults less than 25 years, usually in men, arises in the cortex of long bones. Presents as bone pain that resolves with aspirin. Imaging reveals a bone mass. Bone mass are less than 2 centimeters with a radiolucent core, osteoid. So it is being shown here. So osteoblastoma is similar to osteoid osteoma, but is larger, arises in vertebrae and presents with bone pain that which does not respond to aspirin. So osteoblastoma ni navango ni exception. Mu gihe izindi ndwara tumors zose zirangizwa na blastoma, zifite Swiss blastoma ari embryonal tumors and are very high grade cancers. Osteoblastoma ntabwo ari cancer ubwayo. It's not a cancer. It looks like a benign tumor. So osteochondroma mu Kinyarwanda bakunda kubyita inkabya, ni agashami kaza kuri bone. So umuntu abanga afite inkabya wenda kuri ku kiganza, ari akagufa kamwe kakuze kakagera nk'ishami. That is osteochondroma, and I understand that it is a benign tumor encompassing both the bone and the cartilage. Kuri histology icyo tubona nuko tugomba kubona ko hari igice cya bone gihita gihura straight forward na bone marrow. Kuri histology when you see that it is, we confirm it is osteochondroma. So osteosarcoma now it is a cancer, and here there is a diagram showing the distribution of osteosarcoma. So icyambere muri kubona mwese nuko ari indwara ikunze gufata ntabwo ari kenshi ifata muri diaphyse, ahubwo ni around metaphyse epiphysis nakunze kubiri. So this means it is usually around a joint. Kuko mubona hano iri kuri upper humerus or here lower femur or upper tibia. Mnaona kwenye shari naho ziba around the knee joint. Others are around the hip joint, others here and also in the maxillofacial area. So it is a malignant proliferation of osteoblasts. Kandi murabyuka twayibonye ko risk factors ziyi harimo Paget disease of the bone. Ya indi igira osteoblastic activity iri hejuru ivanze ishobora kuvanga na osteoclastic activity nayo hejuru. So osteosarcoma hafi zose tuzibona mu bana batoya imyaka 20 cyangwa itarenga ngaho niho dukunda kubabona, zirahari naho mu Rwanda. So risk factors are retinoblastoma, Paget disease, and radiation exposure. And familial retinoblastoma, I think when whether in general pathology, just twavuga kuri retinoblastoma gene, ndetse n'igihe twavuga kuri retinoblastoma nka cancer yo mu jisho, twabonye ko ira gene yiswe gutyo kubera ko babonaga iri mutated muri cases za retinoblastoma, ariko nyuma waje gusanga inaba mutated in other cancers including osteosarcoma. So as I was saying, this arises from the metaphysis of long bones, usually in the distal femur or proximal tibia around the knee. So I think this is a part of your assignment, of course. So it presents usually as a pathologic fractures of bone or bone pain with swelling. Imaging reveals a destructive mass with a sunburst appearance. So see here in the pictures, here in the X-rays, and the lifting of the periosteum. So kubera ko itangira munsi ya periosteum, iyo itangiye gukora periosteum ireguka, so bikora triangle bise Codman, umuntu ayivuze bwa mbere. And so biopsy will reveal promorphic cells that produce osteoid. So iki ni ingenzi cyane kubona osteoid, kubera ko hari indi cancer tubona yitwa chondrosarcoma yo iva muri cartilage. Iyo tuyibonye ikintu cyane twitondera nuko niba hatarimo osteoid, bako nubwo yaba ari hose ubona ko ari chondroblast ariko akazamo osteoid na gato, diagnosis yitinduka osteoblastoma, and the treatments are very different. Ibyo tunabyitaho cyane kubera ko osteosarcoma ifata abantu bakiri bato, around 20 years, mu gihe chondroblastoma ifata abakuze. So iyo tubona umuntu yari afite imyaka 40 ukabona afite features okay, umuntu afite 20 years afite features of chondrosarcoma, ubyibaza niyo mpamvu ushaka byanze bivuze niba nta hantu hari osteoid. Ikindi nkiranga navuga nuko osteosarcoma nubwo ifata abantu b'imyaka 20, iyo iturutse ku yindi ndwara iyo atari primary, ahubwo yaturutse nko kuri Paget disease, iza umuntu akuze. So that is a diagnostic exception. So umuntu ufite Paget disease agira osteosarcoma active, cyangwa se umuntu wavuwe indi kanseri igakira bamuvuje radiotherapy, aba afite risk yo kuzagira osteosarcoma akuze. So that is more. I think you remember we saw it when we discussed retinoblastoma. So giant cell tumor, it is a tumor composed of martiniacal giant cells. Now murazibona, this is one cell with many nuclei inside. Zimwe mwabonye muri granulomas, muri tuberculosis. Affects younger adults, arises in epiphysis of long bones, usually the distal femur or proximal tibia. So there will be soap bubble appearance on X-ray. So locally aggressive tumor may recur, although it is aggressive, it is not a cancer. It behaves like a cancer, but there are no cancer cells there. It is just destructive. So Ewing sarcoma, I will maybe add another word here. Yeah, no more Ewing. No, this name is eh, yafashe izina ry'umuntu wayivumbuye nibyo bita eponine. So ariko ikibazo cy'iyi yavumbuwe n'abantu babiri ibihe bitandukanye ahantu hatandukanye, nako ibihe bigenda kuba bimwe ariko mu ahantu hatandukanye. So umwe yarabibumba aravuga ati jyewe nabonye tumor of the bone yitwaga Ewing ifite amasereri ameze gutya na gutya. Undi nawe ahandi aravuga ati jyewe nabonye tumor iva muri soft tissues isa na primitive neuroectodermal cells. So we ayita primitive neuroectodermal tumor PNET. Uyu we barayimwita bayita Ewing sarcoma. So bibaho ngaho uko abantu bahura mu manama baradisita baza gusanga ni indwara imwe ahubwo no kwavumbuwe n'abantu batandukanye kandi umwe ayibona muri bone undi ayibona muri soft tissue. So niyo mpamvu mu bitabo by'ubuzima bandika Ewing sarcoma / primitive neuroectodermal tumor. So it is derived from neuroectoderm, arises in diaphysis of long bones, usually in male children. So I think you still have answers on your assignment here. So there will be only on skin appearance on X-ray. You can see here. So biopsy reveals small round blue cells that resemble lymphocytes that is shown here. So it can be confused with lymphoma or chronic osteomyelitis. But so dufite markers dukoresha kugira ngo turebe ko ariyo. Hari iyo twita CD 99 niyo ukunze gukoresha. So those who can do genomic testing, this patient they have a translocation between chromosome 11 and 22. It is responsive to chemotherapy. Nubwo tubonye tugomba kubitandukanya n'ibindi kubera ko ashobora kuvurwa gake kandi ko baba ari n'abana benshi kenshi. So ngo ndavuga ndongeraho iryo PNET iriho hano. So chondroma, it is just a benign tumor of cartilage, usually arises in the medulla of small bones in the hands and feet. So medulla, not in the cortex. So again, that is part of assignment. So you can see urutoki rubanziriza uruhera ahangaha ko harimo, there is something here which is radiolucent inside. It is in the medulla and the diaphysis. So chondrosarcoma, it is its counterpart, a malignant one. It arises from the medulla of pelvis and the central skeleton, usually around 40 years of age. And you see that 27% dies from the pelvis, others upper femur, others lower femur, and so on. So ikizweho ni timeri ikura vuba, iryana cyane. So nk'iyo umukoreye surgery ikintu kizabikora ko ari chondrosarcoma, yuko ukasemo na bisturi cyangwa ikintu cyose wakatisha, ubu uhita ubona aho ukase hasa n'ubururu kubera cartilage iri muri icyo kibyimba nyinshi. So ni icyo kiranga cyane cyane. Kuriya no muri pathology, when you have such a bone, it is even at gross examination you can say this is a chondrosarcoma because it becomes blue. So metastatic tumors are more common than the primary tumors in the bones. Usually result in osteolytic, punched out region, cyangwa se osteoblastic. Nyango nabivuze ko cancer zimwe iyo zigiye muri bones, zimwe they destroy, others they bury. So those which bury the bone, they are called osteoblastic. Ikunze kubikora ni prostate cancer. Nyango narabivuze ko nukora mu X-ray muwenda muri vertebra ukabona afitemo bone region, ukabona osteoblastic, it doesn't destroy but it buries the bone. So bigatuma bone iba nini, ibyimba iba nini. So you will confirm this is osteoblastic tumor metastasizing here. Niba ari umugabo, ikintu cya mbere uzihutira ni kwa prostate. Mu gihe izindi cancer nyinshi ziba osteolytic. Okay, question so far. So if no questions, then we take a break. I think 10 minutes will be enough. So we come back at 10 past 10.
twari tugifite imyukare.
Sorry?
科学，就这个。
嗯。
Okay. Welcome back to the presentation. I hope you hear me and see at the screen. So we are done with bone tumors or the diseases of the bones. So we cannot cover everything. Of course, we covered the most common ones. Any questions so far? So we proceed to the disease of the joint. So as basic principles, so you know the joint is between two bones, and so each bone is covered by articular cartilage, and between this articular cartilage we have this bone a joint cavity, and we have a articular capsule around, and we have a synovial membrane, and it is actually the one producing the synovial fluid which lubricates the joint. So otherwise we have other structures here, the ligaments, the meniscus, and so on. So the first disease is osteoarthritis. You can understand there is inflammation of the joint, arthritis, and the bone, osteoarthritis. So this is actually a degenerative disease, meaning that it becomes as the bone and as the joint is being destroyed slowly. Progressive degeneration of articular cartilage, most common type of arthritis. Most often it is due to wear and tear. So ni ukwera gukoresha izi joint cyane. So uzasanga n'abantu bagira ikibazo muri knee joint, ari abantu bakoresheje amavi nabi. So hari umusaza nzi wa kera wa Mbogo ntakiriho bajyaga batubwira turi abana ngo kera yajyaga abyina yahimbarwa kugira ngo abantu bamushime akabyinisha amavi, ariko ajya gupfa twendaga guturana ntabwo yashoboraga kugenda, amavi yari yarahinamiranye burundu kubera this is a wear and tear. So major risk factors is age. Additional risk include obesity and trauma. Affects a limited number of joints. So it doesn't affect many joints at the same time. So it is an oligoarticular disease. Hip, lower lumbar spine, knees, and the distal interphalangeal joints, and the proximal interphalangeal joints of fingers. So these are the most common sites. So it depends on, of course, on where you have been traumatized or where you have been using too much. So classic presentation is joint stiffness in the morning that worsens during the day. So mu gitondo haba hari stiff, aho ati mu gitondo sindambura amaguru cyangwa sindambura intoki, kuko abasaza cyangwa abakecuru baza kuba ari nkuru, hanyuma akavuga ati noneho nyuma yaho byirirwa bindya, noneho bikagagara burundu. So pathological features include disruption in the cartilage that lines the articular surface here. So you can see there are the surface here is irregular. It should be smooth, and the inside, just below where the cartilage should be, you have cysts, and this is reflected on histology here, where you have irregularity on the surface, and you have cystic spaces, these which are filled with fluid or empty. Fragments of cartilage floating in a joint space are called joint mice. So this you can see them on histology, on a biopsy, or during surgery, or on imaging. Epination of the subchondral of bone osteophyte formation. Osteophyte ni utuntu tumeze nk'uduhwa tuza kuri bone hariya, nyango none twaje nitwo tumujombagura n'akaribwa cyane, noneho ntabagikoresha joint na gato. So nyango izi osteophyte zikunze kuza cyane cyane ko kuri vertebra, kuri vertebra no zikunze kuza. So urabibona no kuri x-ray muramufatira bati ndibwa umugongo, ukabona ko hari excroissance cyangwa overgrowth of on the bones of on the vertebra. So osteophyte categorizes in the in the distal interphalangeal and the proximal interphalangeal joints of the fingers. So you can understand that with this condition, it will be not possible to use the joint as it was before, because it will be painful, cartilage is not there, uh, there will be pain. There will be pain if you use that movement, that joint. So another condition is rheumatoid arthritis. Nayo abantu bakunze kwita rubagimpande abakecuru. So it is a chronic systemic autoimmune disease. So it will not be oligoarticular as the previous one, because this is systemic that affects many joints. Classically arises in women of late childbearing age associated with HLA-DR4. So it is characterized by movement joints. The hallmark is synovitis, meaning there is inflammation in the synovial space, leading to formation of a panus, or which is inflamed granulation tissue. This leads to destruction of cartilage and ankylosis. So nira ya mbere tumaze kubona harimo destruction of the cartilage, ariko hano hiyongeramo icyitwa ankylosis, ni ukuvuga za cartilage ziba destroyed, no zikanagerana igufa rigafatana n'irindi, ugasanga niba fima yafatanye na tibia byabaye nk'igufa rimwe ntashobora guhinuka ukuguru kundi, and so on. But usually it affects smaller, the rheumatoid arthritis usually affects smaller joints and the knees and so on. So I think here these figures are showing where the areas which are most affected. The distal interphalangeal areas and the proximal one, and then you see now what happens, the deformity which it shows after that in the joints. So as we said, there is an antigen or a microbe which will induce that which is usually not known. Ikiboneka no kuba ari autoimmune, umuntu aba afite antibodies and T cells against the joint itself. Ariko ikintu cyatumye icyo cya mbere kibaho, usually don't see it. It is an assumption that probably an antigen or a microbe induces that autoimmune reactions. So major histocompatibility class 1, as you know, it works with CD4 cells, kandi ireba cyane cyane biri kuri cell membrane at the surface. So here then this antigen presenting cell will present the antigen via the MGS class 2, and then it will present that antigen, the part of the antigen, epitope. It will represent it to CD40 cells. Then these CD40 cells will release cytokines. These cytokines will some activate B cells. As you know, when B cell is activated, it becomes plasma cells and produces antibodies. Other cytokines will work on macrophage, and macrophage, you know, it produces more or other cytokines, which can work on fibroblasts, on chondrocytes, on synovial cells to release collagenase, an enzyme which destroys collagen, stromycin, elastase, and so on. All of these will lead, and together with that, there will be also proliferation of these cells, fibroblasts, chondrocytes, and synovial cells, together with the formation of the rheumatoid factor. Rheumatoid factor ni antibodies abafatanye ari kumwe na antigen na antibodies, so immune complex, they will be deposited in the joint. So all together with this, they will make that panus, granuloma, granulation tissue twabonye kabamo hariya, kagatuma habyimba, and at the end, there will be ankylosis, meaning both bones will be fused. And on the other side also, CD4 T cells, they activate endothelial cells, which will also make sure there is the accumulation of inflammatory cells on that side. So laboratory findings, there will be IgM autoantibodies against FC portion of IgG. Iki nicyo bita rheumatoid factor. Nubona muri laboratory bangwaye gupima rheumatoid factor, ashaka gupima muri biterwa n'ibitaro uko byubatse. Hari aho bijya muri biochemistry, hari aho bijya muri immunology cyangwa muri serology, it depends. But when I say rheumatoid factor nicyo abashaka iyo mu bwoko bwa IgM iba ishaka which destroys or okay, it has attached Fc portion of IgG. That's why it is an immune complex. So neutrophils and the high protein will be seen in synovial fluid. So ahangana ukora ponction puncture in the joint, ukabamo fluid, ukareba harimo iki, neutrophils irimo, harimo protein nyinshi and so on, so it will be you remember exudate as we saw in inflammation. So complications will include anemia and chronic disease and secondary amyloidosis because of the chronic inflammation. So the features, you see the joints, how they are deformed, kandi bija muri extension, urabona intoki zigorama zitaza imbere medially but externally, so on the lateral side. Arthritis with morning stiffness that improves with activity. So icyo bivuga nuko nubwo yafite stiffness mu gitondo intoki ze ziba zisa n'izigagaye, iyo yagumye aho ngaho it worsens, ariko iyo azikoreshe bigenda bimprovinga uwo munsi, ubwo ejo kongera akajya kuri urwo rugamba. So it is a symmetric involvement of proximal interphalangeal joints of the fingers with a swan neck deformity, wrist radial deviation, elbow, ankles, knees, and so on. So DIP is usually spared. So distal interphalangeal joints hano nta kibazo zifite, ikibazo kiri hano. So joint space is narrowed. There is loss of cartilage and osteopenia, which all this you can see them on X-ray. And this narrowing of the joint space means why there are both bones will easily fuse. So other clinical features include fever, malaise, weight loss, and myalgia, pain in muscles. Rheumatoid nodules, it is central zone of necrosis surrounded by peripheral histiocytes, which arise in the skin and the visceral organs. So nukuvuga ko iri rheumatoid nodule ushobora kuyibona ahantu hadafite aho hahuriye na joint ubwazo. Vascularitis, multiple organs may be involved, and you understand because this is an autoimmune disease. Autoimmune disease usually it doesn't involve only one organ or one type of organ. It may affect different organs. So Barker cyst is the swelling of bursa behind the knee, pleural effusions, lymphadenopathy, and interstitial lung fibrosis. So this is because of the autoimmune disease affecting the lungs, destroying the alveoli and so on. So just last study we visited the family. They lost a mother. So that mother had exactly this condition, and she just died because of respiratory problems. The oxygen saturation in her blood could not reach even 80%. So although she was in hospital, and the X-rays was showing her lungs were fibrotic. So meaning that she had developed this condition. Ikindi yagize kandi nuko autoimmune disease nuko mubizi cyangwa muzabimenya, kuyivura nta kindi biragoye. Kuyivura no guca intege immunity y'umuntu. So abaturage bazi no kubisobanura nkaho twasanze n'abaturage bati twarabimenye ko umuntu yari arwaye indwara iterwa no gusubiranamo kw'abasirikare. So autoimmune disease abaturage ni ugusubiranamo kw'abasirikare b'umubiri. So kugira ngo rero uhagarike iyo ntambara no ko bashobora bose guca intege. Kubaca intege nicyo gikorwa. So imiti baba hariho ni steroids, prednisolone, corticosteroids. Ikibazo cyazo zitera izindi complications nazo ubwazo zishobora kwica umuntu. So it is really a very tough task to take care of a person affected by autoimmune disease. Okay. So another disease is seronegative spondyloarthropathies. Arthropathy. So seronegativity means, yeah, when you do serology or immunology, you don't find a rheumatoid factor, any other cause of the inflammation. So this is a group of joint disorders characterized by a lack of rheumatoid factor, skeleton involvement. So mu gihe rheumatoid arthritis ikunze gufata joint ntoya, izi zo zifata skeleton. Axio ni ukuvuga so axe y'umuntu kuva kuri head ukamanuka kuri za vertebra kuri chest naho ngaho. So iyo nizo bita axial bones. So ankylosing, there will be HLA B27 association. So there are then, as here, this is first bullet says, this is a group of joint disorders. So the first one is the ankylosing spondyloarthritis. So it makes ankylosis when there's a fusion of bones around the joint. So this is one, ankylosing spondylitis, another one psoriatic arthritis, enteropathic arthritis, juvenile spondyloarthropathies, and undifferentiated spondyloarthropathy, and also this reactive arthritis. So these are the group. These are the elements of this group of spondyloarthropathies which have no rheumatoid factor. So here then, if we start with ankylosing spondylitis, it involves sacroiliac joints as well as the spine. So here there is a diagram. It is showing in normal spine. So here we have the same spine, but with inflammation. Of course, inflammation, we cannot see it on the X-rays. Inflammation. And there is advanced ankylosing spondylitis. Murabona ko iyi bone harahura ni vertebra hano zifura nini. Mu gihe hano harimo akaespasi kabitandukanye. Hano zaremye osteophytes, twa dushami cyangwa uduha, natwo ubwacu tugenda duhura there. It is ankylosing. If it is ankylosing, ni uko iyo joint ntibigihari, ntabwo iba igikora, nta muvoma uba ushobora kongera gukoresha when there is ankylosis. So it affects the young adults. Question? Most often may present with low back pain, involvement with the vertebral bodies, eventually will arises with fusion of the vertebral. Icyo gihe niyo uzumva bavuga umuntu afite bamboo spine. Bamboo to no spine zabaye nk'ingingo z'igisheke, niba ariko twabyita nk'uko mubibona hanga, kubera ko zirafatanye, vertebra zirafatanye, hagasigara imirongo isigaye yo hagati nk'uko mu gisheke cyangwa mu migano. Bamboo ni imigano bimeze. Extraarticular manifestation include uveitis, means the uveal tract in the eyes, it will be inflamed. Aortitis, inflammation of the aorta, especially if the aortic valve is involved, then there will be aortic regurgitation. Ni ukuvuga igihe umutima umaze gutera amaraso, amaze kugenda muri aorta, ubundi aortic valve iba igomba kwifunga kugira ngo amaraso akomeze agende. Icyo gihe iyo hajemo ikibazo cya regurgitation, ni ukuvuga ko amaraso aragaruka kubera ko valve iri deficient. So the second category is reactive arthritis, which is characterized by the triad of arthritis, urethritis, and conjunctivitis. So ni icyo kiranga, biragaragara ko harimo ikibazo muri urethra, afitemo inflammation, akagira inflammation mu maso, conjunctiva, and then in the joints. So yeah, it is shown here. Anterior uveitis, fluid microscopy will show maybe inflammatory cells. So we have also psoriatic arthritis in 10% of cases of psoriasis ni indwara tuzayibona ifata uruhu, aho usanga uruhu rusa n'urunyenya amazi rukaza ibintu by'ibivuvu and so on. So ni indwara iri grave. Kuri histology ubona ari utuntu turi banal, ariko clinically ni indwara iri mbi cyane bisa nabi. Uburyo umuntu ahindana ntuzongere kumenya ko uko yasaga mwahora ntubumenye. So ni indwara tuzabona muri dermatopathology, ariko bamwe mu barwayi bayifite rero it affects also joints. In that case it will be called psoriatic arthritis. So infectious arthritis is when there is inflammation of the joints caused by an infectious agent. It will be called infectious, usually caused by bacteria such as Neisseria gonorrhoeae and Staphylococcus aureus in older children and adults. And this is the second most common cause after Neisseria gonorrhoeae. So classically, this affects only one joint, especially the knee. Present as a warm joint with limited range of movement. So as you know, there is a loss of function of an organ which is affected by inflammation. Fever, white, this is the white blood cell count. So, and elevated erythrocyte sedimentation rate. So all the features of inflammation will be seen. And when you do punction, you puncture the joint, this articular fluid, you will find there are white blood cells in that fluid, and you can isolate bacteria. Nicyo kizaba bitandukanye na ziriya tumaze kubona hejuru zo ntabwo zaba zirimo bacteria. So another condition is gout cyangwa gute, ngira ngo mujya mubona abantu babirwaye baba bafite akantu k'agatofayi cyangwa akantu kameze nk'akabuye kari muri joint. So akenshi muzabibona baba bafite mu ino rinini ry'igikumwe niho gakunze kuza ako kantu, ariko it can affect anyway. So this tophus is composed of monosodium urate crystals. And this happens in people who are affected by hyperuricemia, uric acid nyinshi. So uric acid iba nyinshi mu maraso cyane cyane ku bantu iyo habayeho catabolism of muscles and so on, bikagaragara cyane ku bantu barya inyama cyane, nibo bikunze kugaragara. Kurya muzabona ku bitaro bazababuza kurya inyama, kunywa inzoga and so on. Ibyo bintu bazabibabuza. Unfortunately benshi muri abo ntibaba babyumva. None abantu babaye addicted kuri byo ku buryo batabikora. Sashibe ni utari hano umurwayi wari uyifite gute barabimubujije, ariko ntawe uza ahantu yanyuzaga abamurwaza banyuzaga inzoga, wabatunga ugasanga bafite za mitsingi n'ibindi, bafite inyama aho ngaho zokeje baguze. So ntabwo yaramye yahise apfa. So probably because the kidneys were affected and so on. So hyperuricemia is related to overproduction or decreased excretion of uric acid. So primary gout is the most common form. Wavuze primary nuko ntabwo ntabwo ibifite indi ndwara yibanjirije. So etiology of this is not known. It's not known. So you see the kidneys is affected. You see many joints being affected. Abantu bafite n'utunodire mu topine mu gutwi inyuma, afite n'utunodire and so on. So secondary gout is seen in people who have had leukemia and myeloproliferative disorders. This is because muri aba barwayi bafite white blood cells nyinshi, bituma bagira increased turnover of cells. Nuko serire bakora sere nyinshi kandi zikicwa ari nyinshi, bityo uric acid ikorwa ari nyinshi. Others are those presenting with Resch-Nihan syndrome, which is the X-linked deficiency of this enzyme. So this also they present with mental retardation and self-mutilation. So renal insufficiency also is one of the causes of gout, because the kidneys are the ones excreting the uric acid. If they are not, kidneys are not working properly, then uric acid will be higher in the bloodstream, and therefore they bring about this disease. So the acute phase of the gout presents as the expiratory painful arthritis of the great toe. So this is about the podagra. So I was explaining that niho ikunda kugaragara n'ubundi. So these crystals, monosodium what? Monosodium urate. Crystals will deposit in the joint, triggering an acute inflammatory reaction. So kubera ko izi crystals ubundi tuba tumeze nk'utuntu tw'udushinge tugenda tujombagura muri iyo joint, uko tuhajombagura dutuma hazamo another additional inflammation, because tissues around will be injured and then the inflammation will come there. Ibyo byose nibyo bituma igenda ikura, uko iminsi igenda niko inflammation irushaho kwiyongera, na twa duto fast patonodil natwo tukaba tunini kurushaho. So as I said, alcohol and consumption and meat consumption, they precipitate the inflammation. So for the chronic gout, it leads to the development of toffin, which are white, chalky aggregates of uric acid crystals with fibrosis and giant cell reaction in soft tissues and the joint. So you see the nodules here, 2 nodules. And here you can see crystals, which look like needles. Okay, these needles, you can see them under polarized light in the microscope. So that's all for this, the diseases of the joint. Otherwise, hari tumors za joint ntabwo ari nyinshi, ni nke cyane ibyo bita by the way, hariyo turagaruka yitwa synovial sarcoma, mwabyumva nkaho ari cancer iva muri synovial cells, niko yiswe, ariko nyuma baje gusanga 10% zonyine zayo nizo ziva kuri joint, otherwise ni cancer ituruka ahandi hantu. So far there is no true tumor of the joint itself, no. So if you have questions, you can ask, and if not, we proceed to the next part.
I have a question.
Yes?
How is gout treated?
Yeah, I'm gonna resolve gakeya. The gout, the treatment of the gout will focus on the lifestyle. So if we know the conditions which can precipitate the disease, so first, there are different drugs which can help maybe the kidney to excrete more of the uric acid and so on. This is one. Ariko icyo gihe ni ukuvuga ni ukwirinda ko hagira uric acid yiyongera ku yari yarabaye igeze kuri gout. Atazi niba haje tofasi nta kizayihakura ubwacyo, uretse ko ushobora kuyikoramo surgically. Ikindi no kwirinda additional inflammation, further inflammation. Niko twabonye ko the conditions which precipitated the inflammation include alcohol consumption and meat. So it will depend mainly on the lifestyle. Ibindi ni imiti ibafasha ibagabaniriza uburibwe, noneho nishobora gutuma hatabaho additional uric acid deposition. This is what I can say. So uzasanga izi ndwara zifata joints inyinshi ni nka palliation. Na abarwayi bafite imiti za diclofenac, ibuprofen bahorana buri gihe ayifata kubera ko nta kindi. So nk'ejo aho ngo njyewe mfite umurwayi rwanjye impande muhorana ibinini n'ibindi. So otherwise I think what we are covering here nibyo abaziga orthopedics, so our medical doctors who will do specialization in orthopedics muzayemo bigarukaho cyane. So you will know more how to treat them because there are always advances in medicine. Akenshi bajya bavuga iyo wize ibintu muri medicine nyuma y'imyaka 10 hafi ya byose ibyo bizaba byahindutse. So that's why we need to always we keep updating ourselves. Niyo mpamvu tujya bita continuous professional development. Ntabwo tutazakomeza ku bya kera kandi ibintu byarahindutse. Ahari muzakugera icyo gihe hari imiti yavumbuwe, I don't know, especially those who do orthopedics. Zamureba joints, mureba amagufa, and so on. So skeletal muscle, so we just see inflammations and the other conditions. We don't see here tumors. We come back on them afterwards. So dermatomyositis, it means there is inflammation of the skin, dermatitis, and the muscle myositis. It affects the skeletal muscle, of course. Unknown etiology. Some cases are associated with carcinoma, such as gastric carcinoma. Ugasanga umuntu afite kanseri mu gifu ariko akagira n'ibindi bibazo nta hantu bihwata ko yagize metastase, ahubwo ari uko byaje aho ngaho ku buryo no gusobanura iyo link bisa n'ibidakunda, ntabwo bikunda. Cyangwa tukiranga hari ibindi byinshi tutazabona, hari nk'indwara yitwa cellulitis. Cellulitis yo ni inflammation of the subcutaneous tissue. Umuntu akagira inflammation munsi y'uruhu ariko itagera muri muscles, niyo bita cellulitis. Niyo bita cellulitis. Hari umutegetsi hano mu Rwanda washize bamwe bandika kuri Twitter, kunda kuri Twitter waserezaga abantu babakubye imyambare n'ibindi baga bati niba abantu barwaye cellulitis bakabuza abandi kwambara uko bashaka and so on. So ni cellulitis after inflammation of the just below the skin, not affecting the muscles. Why when it affects muscles, it will be called dermatomyositis. So it usually affects proximal muscle. There will be bilateral proximal muscle weakness. Distal involvement can develop late in the disease. Rash on the upper eyelid, they call it heliotrophis rash. Mara rash, no kuvuga around the maxilla and so on, hano mu maso hasi. Red papules on the elbows and the knees and so on. Laboratory findings, they have increased creatine kinase. This is an enzyme we test in the bloodstream. Positive, this is anti-nuclear antigen and the anti-Jo1 antibody. Perimysial inflammation, characterized by CD40 cells, which just infiltrate the muscles with perivascular atrophy on biopsy. So the figures is shown here. So when you tuvuze atrophy of the muscle, so uko muscle y'ubwayo baye ntoya ubwayo, cyane kuri storage tubibonera ko muscle fibers zasimbuwe na fat. Yo mpamvu hano mubonamo whitish area, these are fat deposits. So there are adipocytes inside the muscle, which should not be in a normal muscle. So because this is an inflammation and it looks like autoimmune, so usually they treat with corticosteroids. So polymyositis, this is inflammation of the muscle, skeletal muscle. It resembles dermatomyositis, but here the skin is not affected. The skin is not affected. So here the cells which are involved are more CD8 in difference to dermatomyositis where we saw CD40 cells. Yeah, there will be also necrotic muscle fibers on biopsy. So this figure is talking again about dermatomyositis, but in polymyositis they say it is dermatomyositis without rash and no other identifiable inflammatory myopathic cause. So X-linked muscular dystrophy, ubwo murabyumva ko iri transmitted genetically. And the gene involved is on chromosome X. Yango murabyumva icyo gihe iyo kuri chromosome X ifite uburyo iba transmitted, ni ukuvuga uburyo niba ari recessive, ni ukuvuga ko umudamu ashobora kuyanduza niba ariko twabyita umwana we w'umuhungu very easily, kubera ko umuhungu aba afite 1X chromosome. So this is a degenerative disorder characterized by muscle wasting and the replacement of skeletal muscle by adipose tissue, as I was showing there. But there it was atrophy because it was just some few fibers which were replaced by adipose tissue. But in this X-linked muscular dystrophy, almost the whole muscle will be affected or will be replaced by adipose tissue. So this is due to dystrophin gene. The dystrophin gene is important for anchoring the muscle skeleton to the extracellular matrix. Mutations are often spontaneous. Large gene size predisposed to high rate of mutation. So we have different diseases in this category. We have Duchenne disease, ari nayo yiganje nayo turavugaho, Becker muscular dystrophy and Emery muscular dystrophy. And you see that all of them, they have mutations in X chromosome. Duchenne and the Becker muscular dystrophy, they have mutation in the same area in X chromosome short arm region 2-1. And here in Duchenne, protein zakorwa izaba ibuzemo dystrophin ibwayo ntabwo izaba ihari. Mu gihe muri Becker muscular dystrophy, this dystrophin will be there as a residual protein. No kwaza izaba zirimo nkeya mu gihe hejuru nka protein nimwe izakorwa. So that is the main difference. Otherwise they are almost the same. While for the other one, the emerging protein will be the one which is deficient. So here we see only one disease, Duchenne disease, which is due to deletion of dystrophin bituma. Deletion, it means the gene responsible for forming that protein is absent. That's why also the protein will be absent, of course. So clinically, there will be proximal muscle weakness at 1 year of age. It progresses to involve even the distal muscles. So you have the proximal muscle, tuvuga niba ari ukuguru izo hejuru ziri kuri around the femur will be down proximal, then izo hasi kuri tibia and so on will be distal muscles. Calf pseudodystrophy is a characteristic finding, and there will be increase again serum creatine kinase. So usually there will be death due to cardiac or respiratory failure because the myocardium will be also involved. So it means this doesn't affect only skeletal muscles, but it's also it can affect the myocardium. So NS-related muscle. That is the meaning. So Becker is due to mutated dystrophin. Clinical results in Mirida disease. They have some protein, some dystrophin protein, few, as compared to what should be done. So here the Duchenne muscular dystrophy to show the signs and the symptoms, progressive muscle weakness and the atrophy, calf muscles hypertrophy, fatigue, walking agendera ku mano, maybe because the muscles, other muscles are weak, you know what? So difficulty climbing upstairs, frequent falls, developmental delays, mwana uzatinda guhaguruka cyangwa kumakamba, breathing problems, learning the differences, the delay speech and language development, scoliosis, and the short stature in height. So these are some of the characteristics of this Duchenne dystrophy. So the next part is the neuromuscular junction problems. So you know that for our muscles to work, they are innervated. So nerves, they are the one giving a command to a muscle either to contract or to relax and so on. So if that neuromuscular junction is defective, the communication is not good. You understand the consequences is that the brain will not control what the muscles do. So the disease we are to discuss here is the myasthenia gravis. So asthenia ni ukuvuga umuntu yari yabaye asthenia kunanirwa. Mere muscles. So ni ukuvuga ni indwara isa naho isobanura ngo muscles zinaniwe. So this is an autoimmune disease whereby autoantibodies against the post-synaptic acetylcholine receptor of the neuromuscular junction exist. So here we have a muscle and a nerve. So the problem here is, you know, a synapse. Okay, reka dutangire hejuru. Here we have a nerve and a muscle. So aho nerve ihurira na muscle, iyo niyo synapse nk'uko mubizi. Ariko hariho n'ubundi bwoko bwa synapse. You know that in physiology, don't go back there. So this is the nerve cell and this is the muscle. If you take a section, what happens? You know that when the message comes from the nervous system through a nerve, for that message to be transmitted to a muscle, ntabwo ari itwara amakuru mu bundi buryo. It uses just ions, sodium, calcium, and so on. And to do that, we have some I can call them messengers which help in that, neurotransmitters. Neurotransmitters such as acetylcholine. So acetylcholine here, you see that it is only the muscle side for the synapse. So for it to work, it needs the sodium. So the problem here then, it means, as it is explained here, there are antibodies against the receptors to acetylcholine. And because of that, sodium is there, acetylcholine is there, but its receptor, it doesn't work. This is what you see here. So because of that, sodium will not pass through this way. Kuri sodium twabivuze ko niyo amakuru aje ntabwo atangwa mu magambo, ahubwo atangwa mu buryo bwa ions na sodium n'izindi. Igihe rero nerve izanye amakuru akagera hano ntabwo yageze kuri muscles, ayo makuru ni ukohereza calcium cyangwa akaza sodium so. So if the receptor here is not working, then sodium ntabwo akazi kayo izagakora, ntabwo izava hano ngo ihite muri iyi receptor yinjire muri muscles. So understand now the consequences that the muscle, it will not receive the message coming from the nerve. So it is seen that, observed that this disease affects more women than men. They have a muscle weakness that worsens with use and improves with rest. So icyo bivuga nga nuko receptors zose ntabwo ziba zifite ikibazo, haba nkeya ziba zishobora kuba zikiri nzima. Izo rero iyo ukora ibintu bikeya ushobora kubikora ntugire ikibazo, ariko igihe ukoze akazi kenshi cyangwa akazi gato ariko gakora umwanya, na za zindi ziba exhausted, so umuntu agahita ananirwa vuba. Muscle weakness which will worsen with use. Waruhuka ukumva nawe urakize, ukabona muscle zirakora, niba akazi wakoraga kuribwa n'ibindi wagiraga bigahagarara. It classically involves eyes leading to proptosis. So that it is ptosis. The propria ni uburyo umuntu areba mu kintu kimwe akabonamo ibintu bibiri. Symptoms, they will improve with anticholinesterase agent. So ni drugs mutanga, so those who ask for treatment, you understand. what treatment you should give if you diagnose this myasthenia gravis. So it was seen that people are developing myasthenia gravis. Most of them, they have a thymic hyperplasia or thymoma. So murabizi ko umuntu avuka umwana muto afite timas nini ariko uko akura igenda iba ntoya because of the apoptosis, uko umuntu agomba kubaho itagabanutse rero agakomeza kuba nini akagira hyperplasia or even a tumor thymoma. This will predispose to have this myasthenia gravis. So when you have a patient with myasthenia gravis, you should do imaging of the neck to see if there is no thymoma or thymic hyperplasia. If it is there, then do surgery, then the symptoms will be improved. So another neuromuscular junction problem is or disease Lambert-Eaton or Ayrton syndrome. So iriya twabanje kubona myasthenia gravis twabonye ko ikibazo ni antibodies against post-synaptic sodium channels. Ahangaha it is the opposite. It is antibodies against pre-synaptic calcium, not sodium channels. So ngira ngo principle nimwe n'ibindi. So it arises as a paraneoplastic syndrome. Paraneoplastic syndrome, you remember when someone has a cancer, which releases some maybe some enzymes and especially hormones, which should not be released by that affected organ, maybe paraneoplastic syndrome. So usually it is seen in people having lung cancers, as I have explained this many times. So there will be impaired acetylcholine release. So filling of presynaptic calcium channels is required for acetylcholine release. So if then that calcium is not filled, that is a presynaptic channel is not filled with calcium, you understand, acetylcholine will not be released. So they have a proximal muscle weakness that improves with use. You understand the difference. In myasthenia gravis, the weakness will worsens with use. And here it is the opposite. It will improve with use. Eyes are usually spared. So this is another difference. In myasthenia gravis, eye is usually affected. So another thing, if you give cholinesterase agents, they will not improve. So all of these, they can help you to diagnose which is which among these two. So if, because we saw that usually it is caused by a paraneoplastic syndrome, if you do surgery to the primary cancer, the disease will disappear. So the problem is when the cancer it can't be resected. So that's all here. Then we go to soft tissue or tumors. Questions so far? Okay, so we proceed. So soft tissue tumors, they are many, they are difficult. I think for pathology, this is the most difficult part for us, for pathologists, of course. So for you, maybe you don't mind because you are not a specialist. Arikyo, our pathology, and I mean those who do specialization in pathology, this is the most difficult part. Cyane cyane iyo ugiye muri pratique, and we shall see it is explained the reason this is very difficult. So the basic principles, as you know, we have the histological diagnosis of soft tissue tumors. Some they arise from fibrous tissue, such as fibrosarcoma and others. Others from peripheral nervous tissue, such as schwannoma, neurofibrosarcoma, and so on. Others from smooth muscle, such as leiomyosarcoma and leiomyoma when it is benign. Adipose tissue, lipoma if it is benign, and then liposarcoma if it is malignant. And you have many subtypes of liposarcoma. We have sarcomas of blood and lymph vessels such as angiosarcoma na Kaposi sarcoma. It is a cancer ikunda kugaragara ku bantu bafite HIV. Tuzayigarukaho muri dermatopathology, mpamvu hano tutayitinzeho kuko akenshi ifata uruhu niho tuzayigarukaho. So it is gusa nubwo ivuga ko iva muri vessels. Until now nobody knows niba ari blood vessel or lymphatics. So ikunda kugaragara abantu bafite HIV, murabona ubu basigaye bafata imiti bakimenya ko banduye, ariko mbere bafataga imiti bamaze kugira ibimenyetso byinshi, CD4 counts zabo zagiye hasi cyane, bikadutangira za stage twebwe umuntu ahabwaga imiti mu waba ugeze CD4 count ziri munsi ya 400, nyuma barazamura bazigira 350, nyuma bazigira 500, none ubu uwo ari we wese ahita ahabwa imiti. So cyari byatewe nuko imiti yari ihenze, corona byari bigoye kandi ari leta zibyishyura. So icyo gihe twazibonaga Kaposi sarcoma nyinshi ko yazaga ari nka opportunistic disease kuri HIV especially. Nowadays they are few. So the sarcomas of skeletal muscle harimo tuyita rhabdomyosarcoma, and we have 3 types: embryonal, alveolar, and pleomorphic. So we have sarcomas of in the joint, but which is not true. We have also others: alveolar soft part sarcoma, epiphyseal sarcoma, and niyo bita clear cell sarcoma, rimwe na rimwe bayita melanoma of soft part. So we have many entities, and you have sarcomas, extraskeletal sarcomas of the bone. So uzasanga unafite osteosarcoma ariko itari muri bone, iri muri soft tissue tugeta ibibona. Then clear cell sarcoma which is the melanoma of soft parts. So these are mesenchymal proliferations that occur in extraskeletal non-epithelial tissues of the body, excluding the viscera, coverings of the brain, and the lympho-reticular system. So this is the definition of soft tissue tumors. They are tumors arising in extraskeletal, meaning not in the bone or cartilage. They are non-epithelial, so they are not carcinomas. They exclude also cancers arising from viscera, intestines, and so on. Coverings of the brain, meninges, or ziraziva muri lymphoma and leukemia. These are not included. So there is a necessity for a team approach and clinical pathological correlation. So this is very important. So ntabwo wavuga ko ibi byose birasobanura impamvu this is a difficult part in pathology. So ntabwo ushobora you cannot easily diagnose this disease if you don't take care of imaging findings or other clinical information. So hari ibyoroshye wenda za rhabdomyosarcoma biroroshye kuzibona, ariko izindi usually it is very difficult. You must correlate many things and also work as a team. So soft tissue benign tumors outnumber malignant tumors. So muri case nk'ijana za soft tissue tumors iri malignant bari imwe gusa. So ntabwo ari nyinshi fortunately if I can say so. So cause is unknown in most cases, ariko hari bizwi nka risk factors. Abantu bahawe radiation therapy, abigeze gutwikwa yaba chemical burn or heat burn, or who have been traumatized in the past, so they can develop sarcomas. And a Kaposi sarcoma, as I said, it is associated with immunosuppression, especially those affected by HIV. So most tumors, they come sporadically. There is no familial syndrome, but for others, there are some genetic predisposition. Have it neurofibromatosis 1. They used to have a neurofibroma and a schwannoma, malignant 1. Gardner syndrome twavuzeho kare. Hejuru, so bamwe bagira exophyte cyangwa tugufa tugira amashami. banagira ibindi bibazo birimo nka fibromatosis, bagira fibroma nyinshi ku mubiri, kandi nk'uko twabibonye bakagira na polyps muri colon. Lee-Fromen syndrome, they used to have soft tissue sarcomas, and Osterweiler-Landu syndrome, they developed telangiectasia. This is the malformation of the vessels. So it is very difficult, even for competent pathologists, to agree on the histogenesis of desert tumors. Some sarcomas have multiple cell types present in different areas of the tumor. Ngira ngo hari wigeze kubaza impamvu hari rimwe na rimwe dushobora gutanga wrong diagnosis, nasobanura impamvu, iyi mpamvu nibuka ko nabivuga. So natanze ingero, soft tissue tumors ni ukuvuga bakoze surgery bagafata igice kimwe cya tumor bakacyohereza muri lab imwe ikindi ahandi, akenshi ibisubizo ntabwo biba bibi. This is no. So niho nabahaye urugero rw'abanyamerika bari hano bita HRH icyo gihe, ubu hari indi yitwa HRH. So bari bafite umuco bamwe na bamwe wo gufata yakora babaga bagafata igice kimwe bakacyohereza i Butaro, ikindi muri Amerika, ikindi hano kikaguma hano either Faisal cyangwa i Butare cyangwa CHUK. So nibuka ko habaye insida zitari nkeya nk'izo ngizo, tugatanga ibisubizo bitandukanye n'iby'i Butaro, tugatanga ibisubizo bitandukanye n'ibyo muri Amerika. Kandi buka ko icyo gihe ndi no mu bajyaga i Butaro, ntawe n'umuturiste wari uhari, twari babiri tujyayo rimwe mu cyumweru. So ugasanga nawe ubwawe diagnosis watanze i Kanombe cyangwa CHUK cyangwa Faisal siyo watanze i Butaro kubera specimen zagize zitandukanye. So the explanation is in this first bullet. Nuko mu gace kamwe ka sarcoma akenshi wana serire zidasa n'izubonye mu kandi gace. That makes it difficult. So nyabike nabaye urugero rwo hari n'umuntu bigeze gukorera gutyo igice kimwe cya muri Amerika basubiza ko atari cancer, basanga hano deja twamaze gusubiza ko ari cancer. Abazungu barabatereka dutegeze ibyagiye iwacu muri Amerika bizabanze bone ko byatindaga ibisubizo, byagiye kuboneka umurwayi yarapfuye bigaragara ko ari kanseri imwe, kandi biza bivuga ko nta kanseri afite. First, it requires to be in a team, so to collaborate adequately. So many tumors are also undifferentiated, so undifferentiated that to subclassify them into the histogenic type is close to impossible. Nukuba rimwe na rimwe harati ukavuga this is a sarcoma. So tujya tubibona kenshi, tujya tubibona ngira ko nk'umwaka uje ari cases bohereje Boston, Harvard. So asking for their opinion. So nabo ubwabo bagasubiza ngo this is undifferentiated sarcoma. Iyo ntabwo ari diagnosis. Ariko oncologist ntabwo ashobora kumuvura iyo ngiyo. Ni ukuvuga ubumbuye ngo ni soft tissue sarcoma, ntazi ubwoko bwayo n'icyo buvuga. So zazaga zimeze gutyo. So aho ngaho nta kindi gikorwa, umurwayi avurwa na surgery n'ibishoboka radiotherapy, ariko ntabwo buzi final diagnosis. So aho bikomera hanga no ko baravuga bati niyo ukoresha specialized techniques nka electron microscopy, which of course we don't have here in Rwanda. Even immunohistochemist nubwo iyo turayikoresha kenshi, nubwo wabikoresha kenshi ntabwo ushobora kumenya ngo ni iyihe kanseri. Iyi kanseri yaturutse ku cell, because as I said it many times, for oncologists to give a drug, they must know which is the cell of origin. So all these things they make soft tissue tumors pathology to be a very difficult field. But we have an approach. So dufite approach dukoresha kugira ngo we orient the diagnosis we are giving. Ariko nubwo mvuga gutya ntabwo nawe ari nyinshi zitunaniye. Rhabdomyosarcoma kuyibona, leiomyosarcoma, it is very easy. So ni nke cyane zitunaniye, ariko iyo zitunaniye akenshi usanga naho twohereje hose yaba muri Europe ya muri Amerika nabo there will be no answer. So ziguma gutyo gusa umurwayi akabwira ko ate kanseri ariko ubwoko bwayo butashobora butaramenyekana. So when the histological type of soft tissue has been determined, then we grade the tumor from grade 1 to 4, depending on the degree of differentiation. So iyo iri well differentiated, uyibona ko ari smooth muscle. So say this is grade 1 or grade 2. When it is purely undifferentiated, then it will be grade 4, which in most cases that is most aggressive. So how do you stage? Ngira ngo staging of cancer twagumye tuyibona ubundi iterwa nuko tumeri ingana ite ya it invades how far, how many lymph nodes are affected if they are, is there metastasis or not. Ubundi mu usanga muri carcinomas niko bigenda, ariko muri sarcoma siko bigenda. Impamvu navuga nebyiri, iya mbere ituma itagendera kuri ibyo muri sarcoma nuko utavuga ngo it invaded until where, so how far. Ibyo ntibishoboka kubera ko ibi ubwayo itangira muri soft tissue, mu gihe carcinomas batangiye kuri surface either of the skin or the mucosa. So bityo kuvuga ngo yageze muri mucosa, muri muscularis propria biba byose. So for this one kuko itangiramo aho hagati na hagati, ntabwo ureba ngo it invaded up to where, no. Ikindi icyo bariho hano bareba ni size gusa, ni size yayo. So you see 5 centimeters is the cutoff. If it is less, it will be T1. If it is more, it will be T2. Mu gihe muri za carcinoma tugera kuri T4, akenshi tugera kuri T4, sarcomas ntabwo zirenga kuri T2. T0 is when there is no evidence of primary tumor. When you don't see it, we give T0. Lymph node, so byo ni ibisanzwe zidafashwe ni N0, N1 if there are regional lymph nodes. Ariko ikindi mwibuka hano nuko sarcoma ubu ntabwo zinyura muri lymphatic. When they metastasize, they go through bloodstream. Carcinomas nizo zikunda kunyura muri lymphatics. So nyirango ni akenshi ntabwo nigeze kuvuga hari nyamwaka ushize uyu 2022 niho nabonye case y'umuntu wari ufite rhabdomyosarcoma yagize metastasis muri lymph node. Otherwise nta metastasis muri lymph node. So distant metastasis ni M0 if no metastasis, M1 if there is metastasis. So this is similar to carcinomas. So nyango icyambere nasobanuye impamvu staging hano itandukanye n'iya za carcinomas. Icyambere nuko ni tumeri zitangira ubwazo hagati muri soft tissues, ntabitangira kuri surface. Bityo ntabwo wavuga ngo depth of invasion ingana gute. So ikindi nuko ahangaha muri sarcomas hiyongeramo grading. Muri carcinoma we don't stage according to the grade of the tumor, no. Grade no kuvuga is very differentiated, no ni differentiated. Muri carcinoma icyo nta ruhare bigira muri staging uretse prostate cancer yonyine. Ahangaha rero muri soft tissue tumors also the grade plays a big role. So nubona umurwayi rero afite soft tissue carcinomas akagatabo gashobora kuzagufasha niba kuvuga ngo stage this patient. When umuganga afite abantu benshi bati okay, help me to stage this patient while maybe I'm prescribing and so on or making a transfer windebera. So akagatabo gashobora kugufasha. Cyambere size yo tumor ingana ite, wenda uzafite CT scan report cyangwa ubwo utabifite hari uburyo no kuri ecography bashyiraho kuri seri ukareba uburebure bwa diameter. So it will be stage A1. Niba ari grade 1 ari T1, no lymph node metastasis and no distant metastasis. It will be stage 1B if the tumor is more than 5 centimeters, as you can see. Stage 2A, ubundi nkuko mubona izaba stage 2 byanze bikunze ari uko ibaye grade 2. Mu gihe cyose izaba ari grade 1 idafite metastasis ntabwo izarenga kuri stage 1 nkuko mubona. So you are not requested to memorize this, nubwo wenda ubifasha mu kajya biza, ariko you are not requested, but you must know if in need where do I go to have a natural staging. uko iyi stage ya nyuma niyo izadetermina none iyi byanditse ni wavuga ngo uyu muntu afite advanced disease, iyo igeze kuri stage 3 ubundi bari advanced any cancer. Advanced stage ni 3 na 4. So n'umu stage nga nabo ukamuha gatatu kandi wenda ari muri kabiri bigatuma bamuha palliative ka gataha mu gatatu ntabwo imiti ya mu palliation gusa, urumva icyo uzabukoze. That's why it is important to accurately stage each patient. Of course, hari information zimwe ushobora kuba udafite, niba udafite information on metastasis, then uzavuga okay, reka dusabe radiologist. Musabe akore X-ray or CT scan of the liver, the brain, and the lungs. Wenda ngono henshi itazezi kumwe so cyangwa bones ubwazo bakareba basanga ari ntayo, then the stage. Ikindi uzabaza pathologist which is the grade niba atayitanze. Atatanze grade uzamubaza please tell us the exact grade because you see it is important. For cytogenetics ni biraba bapima bareba niba chromosome yacitsemo ibice and so on. Ni ibintu bishobora gukorwa muri laboratoire iri muri School of Medicine aho ngaho muri Butare, niyo hari kugeza ubikora mu gihugu. Unfortunately nabo ibintu ntibabikora, bikorera ibindi byo kwa abana bafite abana bafite za Down syndrome, trisomy n'ibindi, ariko ibya cancer ntibabikora. So they told me they have the capacity to do so. Baramutse babonye reagents babikora, but they don't want to go in this. Kandi rimwe na rimwe wanabumva kubera ko urabona izi translocation ni nyinshi cyane kandi izi ni iz'indwara nkeya. So buri ndwara yose ifite translocation, kugira ngo bazabipime byabasaba reagents zizajya expiring kubera ko batazagira abarwayi benshi babipimwa. So ngira ngo ni imwe mu mpamvu batabikora. No, logistics, how can it be done? Kubera ko each translocation, type of translocation uzayisaba, wowe nk'uyisaba nk'ufite umurwayi uzasaba ati mwende akora translocation. Each translocation means specific reagents. Kuri buri kantu wako kagura reagents kandi ni umurwayi mushaka kubona 5 mu mwaka, reagents they will expire. So I think that is one of the reasons. But I think as the country develops, hari abantu benshi bazabikenera n'ibihugu bidukikije, hari centre imwe bipimirwamo ibyo byanga bari byiza kuko yaje bana samples zihagije bityo na logistics zikora. So Ewing sarcoma na navuze kuri bone cyangwa se primitive neuroectodermal tumor ifitemo translocation muri rusange 11-22. So ngira ngo ni ikintu umuntu yafata biroro 11-22 niyo yiganje, nubwo hari ni 22 icyo mubonamo nuko 22 zamo hose niyo iriho gene yitwa Ewing sarcoma gene UWS Ewing sarcoma. Otherwise ye 11 ubwo ni free one, 21 ni ER, hanyuma 7 ni ATV1. So hari izindi nka reka tujye kuri rhabdomyosarcoma turi bugarukeho nyuma. Kuna kwa translocation between chromosome 2, 11 and 13, and the genes which are involved are shown here. So this is what you can say on this in the basic principles. Others, as I said, there are some slides which are hidden and are not shown here because they contain the information that you must give in your assignments. So questions so far before we go to the specific diseases here. Okay, so we start with lipoma. Lipoma, it is a benign tumor arising from adipose tissue. Ni nayo nyinshi muri soft tissue tumors mu bantu bakuru. So it affects the age from 40 to 60. So uzasanga unafite ikintu kiri soft, kitamurya, gikura gakeya, kiri ahantu gusa cyoroshye cyane mu mugongo, hehe ahariho hose ku kaboko. So it is rare in the first 2 decades, no kuva kugera ku myaka 20 bake bayirwara. So males are more affected. Nkuko mubibona hano n'uyireba uhitubona ko ari process surgery, uhitubona ko ari fat gusa. n'udufibers turimo duke utu niko tuba tunyuramo blood vessels zitunganya amasebe, otherwise it has a few blood vessels, ntabwo iba iri hemorrhagic and so on. So on the X-ray, on the histology, you will find just mature adipocytes. So this is one cell ngiyi nini kubera ko yayuzuyemo fat, nucleus yayo ibiri pushed on the side, so iranga nucleus kakari kumukara. So it will have a capsule, nubwo abantu ni small, wenda ni ubwo byatemba, ariko hano iwacu baza kwivuza afite kinini ko wanyuma ntacyo kimutwaye, cyangwa akagira ubwati n'iyo bagasanga ari kanseri ntaze, akaza ari uko nyuma wenda ari hamwe ati ntugire ikibazo. So it is soft, it is mobile and painless, unless when there are also increased vascularizations, niho icyo yitwa angiorythoma, nibwo ibiri painful. So liposarcoma, it is the malignant counterpart. It is the most common malignant soft tissue in adults and common in children. So males and females are affected equally. So kiba ari kinini, gikunze kugaragara ari kinini. So ni cancer ikomoka kuri lipoblast, of course. So lipoblast, at least here you can recognize there are cells which have empty nuclear cytoplasm. Ni uko ziba zirimo fat ikavamo muri processing. So this muri histology nuko hari usanga iyi tumor imeze nk'aha hagati, nk'aha hatarimo adipocyte nini, ukabona ni fibroblast. So in that case it becomes very difficult to know if it is the liposarcoma. So leiomyoma, benign smooth muscle tumors, dukunda kuzibona muri uterus, niho izo tkunze kujya, ariko zishobora gufata ahantu hose hari smooth muscle. Ikindi nuko hari iziva muri skin, kubera ko muri skin muzi ko hari rectal pili muscles. Muri skin izi zishobora kuvamo nazo, they are smooth muscles, so they can develop leiomyoma. I remember there is a case they had, I think they to search it in 2014 or 2015 in the dermatology. Then the dermatologist we discussed it, so she said that no, this is, I think she was thinking about a very severe disease. On histology, no, I said no, it is just a smooth muscle. So they happen, they are rare in the skin. So ikindi ku abadamu barazigira benshi, ariko ikibazo ni ahantu iri, ntabwo twagarutse turayibuzaho gaca muri female genital system. When they are on the surface of the uterus, nk'izi akenshi nta bimenyetso zitanga, usibye ko byaba binini umudamu yakora akunda akacyumva, hano muri uterus ntabwo ashobora kuyumva ubwayo, aho ngaho niho amenya ko afite ikibazo. Otherwise ikindi gishobora kubitera ni nk'iyi iri aha, hari igihe aka kantu kayifatishije kuri uterus kaba thin ikihotora, icyo gihe bihinduka ischemic then painful. So ni icyo ngikunda tumazi. So hari izindi ziba zirimo muri just around the endometrial cavity. Izo consequences zazo nuko zizatuma umudamu atatwita, azasama cyangwa se ntabashobora gusama, ntabwo umwana azabona aho akurira, so ahita agira avortoma inda ikavamo. That is another consequence. Iyo iri muri intramural area inside the myometrium mo hagati, ishobora kudateza ibibazo byinshi, ariko igihe umudamu agiye kubise hari contractions zikomeye cyane, uterus ishobora guturika. So that's what I can say about it. So nyabukino ngiye kuvuga rero ni risk factors, ko ikigaragara nuko abadamu bazigira ni abatarabyaye cyangwa batinze kubyara, nibo bakunze kubigiza, cyane abantu batabyaye, abakira n'abandi usanga abenshi babifite. Ibindi bimenyetso ntavuze, ya yindi yo iri hafi ya endometrium, one of the signs nuko ava even outside the menses, agahora ava, so akaza I have a bleeding. So medical term ni metrorrhagia. So you would have outside the menses. ava ibiva muri uterus. So leiomyoma, I see that it is also frequent around 20% of soft tissue sarcomas. Most develop in the skin and the deep soft tissues of the extremities and the retroperitoneum. So abafite nabo ni smooth muscles rimwe na rimwe bo practically kuri je ntabwo nigeze ngorwa no kuyidiagnosing ati for me it is not difficult to diagnose uburyo selile za ziteye. So for me it is easy, it is not difficult. So hari n'igihe usanga isa na leiomyoma. So iyo tugize leiomyoma ariko tugasanga harimo igice kiri necrotic, this is very dangerous because the sarcomas usually have a necrosis, while benign tumors usually there is no necrosis. So it is written here a geographic areas of necrosis. So we count mitosis. So ubundi kugira ngo tutange grade ntabwo tuyitanga mu kirere, dufite ibyo tugenderaho ubona ngo tutange grade from 1 to 4. Ikimwe tureba ni ukubara mitose ujya kuri high power fields HPF minute high power fields kuri objective ya 40, noneho ukabara ukavuga ati reka njyewe kuri iyi microscopic field ukabara mitose ubonye, ukimuka kuri indi field ukabara mitose zose uziteranije umaze kureba fields 10 ibyo ubonye nibyo wita ngo I have seen maybe 3 mitosis per 10 higher power fields. So no urugero hano. So I bet this is the dangerous. I remember when I was doing my residency. So I did my residency in Tanzania, in Dar es Salaam. So I had a patient, a man, it was maybe around 50 years. So he had a tumor on the leg. Then with the diagnosis of osteomyosarcoma. So we went in a tumor board ni inama ihuza abaganga n'ifiri zitandukanye to decide what to do to each cancer patient. So because the pathology is always like they work as a secretary of that board, but I don't fit amakuru yose y'umurwayi and so on. So batubaza bakanishana baba umurwayi wacu yafashwe gutya so on, radiologist baba twabonye ibi, then oncologist ni uyoboye inama buri akenshi akabaza pathologist, what have you seen? So we said, so we saw it is leiomyosarcoma. I remember they asked me a question. So how can you explain it to have a leiomyosarcoma on a leg where you don't have a smooth muscle? I said, but there are blood vessels there, and you have a skin which has also some smooth muscles, although they are small. So they are confusing. So about the problem, I have to say, nuko muri soft tissue tumors ubundi treatment ya mbere ni surgery ukamenya kwikuya kukuyeho tumor uyimaze. So that person, they had done amputation and the margins were negative. So noneho baravuga okay ubwo cyavuyeho cyose nta kibazo, but I told the oncologist, but I read in literature there was a report in the country bari afite abantu bagize exactly n'uyu murwayi twari dufite abari bafite leiomyosarcoma mu kuguru, hanyuma muri nyine baravuga bati margin negative bakimazeho barabareka, ariko muri nyuma y'imyaka 2 60% bose bagize metastasis, bagaragaje ko bafite metastasis. So I was just asking him to allow that patient to get also drugs, chemotherapy. So he said, no, it is not necessary. So I remember just in around 12 months, that patient came back with metastasis in the lungs. So I feel bad, of course. Bad. So it means the one it is that leiomyosarcoma can exist in anywhere because we have a smooth muscle in the blood vessels and other structures. Second is that even if the margins are negative, don't be just satisfied with that. With sarcomas, hari ubwo selile ziba zaratambutse zitagaragara kuri microscope, of course, zikaba ziri ahantu wamara kumubaga uvuga ngo margin negative, zase zo zikakurira aho zagiye, then akagaragaza metastasis. Kandi iyo umuhaye ya miti imbere na ya maseri atagaragara ya miti irayica amaserire, then umurwayi akaba yakira burundu. So benign tumors arising from skeletal muscle ntabwo tuyivugaho, ni nkeya. Personally have never seen it. So izo mbona ni izindi benign tumors, and then rhabdomal sarcoma, which is a cancer arising from skeletal muscle. So this is the most common cancer of soft tissue in children. I think it is true even here in Rwanda. So fortunately rhabdomal sarcoma hano barayivura mu Rwanda, bavura i Butaro, bafite imiti. So surgery kenshi babohereza CHUK, then cyangwa i Kanombe, then imiti i Butaro, radiotherapy when needed i Kanombe. So rhabdomyoblast niyo serire iba yatangiyeho bien sûr, and it is decimine positive, ndetse hari n'undi decimine. Me personally ntabwo nyikunda iyi marker kuyipima kubera it is not specific. So hari n'iyitwa myogenin niyo dukunda gukoresha at our hospital. So the most common site is the head and the neck, and while in females it affects mainly, it is in the vagina. So harimo ubwoko bwinshi ukurikira histology. Hari iyo bita embryonal. This has a favorable prognosis. Embryonal rhabdomal sarcoma. So if it say duto tumeze nk'utulymphocyte, while alveolar rhabdomal sarcoma, it makes things which look like alveolar, nk'iyi ngiyi ahangaha. So you find an empty cavity nk'iyo muri lung alveolar. Niyo mpamvu bayise alveolar rhabdomyosarcoma. It has an unfavorable prognosis. Ikunze kugaragara ku bantu bakuze muri extremities zabo, mu gihe embryonal akenshi ni y'abana. Pleomorphic it has the worst prognosis. Injangwe ijambo pleomorphic ubu batanye no kurikuraho muri new classifications. Bakunze kuvuga ngo tuyite gusa undifferentiated sarcoma. So ariko iyo ubibona ko ari rhabdomal sarcoma ushobora kuyita ko ari ikibazo ni cya kindi kigaruka. Iyo ukoze izi immunohistochemistry ubonamo amaseri amwe ari rhabdomyoblast, ariko andi ugasanga ameze nka rhipoblast bitewe n'agace wafashe. Nibyo bya yindi twavuze kare bigorana kumenya neza iyi kanseri iyo utarebye ikibyimba cyose usanga ukareba agace gato. So then I was saying this is treated in Rwanda. So hari abarwayi, hari abasurviving bahari, abana cyane kuko bakunda kugira embryonal carcinoma, sarcoma. So they are survivors of this cancer. They are. The weapon, whenever you suspect it, then you send the patient as quick as possible. So rimwe na rimwe ifata mu jisho nk'ahangaha ukagira ngo afite retinoblastoma and so on, wakora biopsy ugasanga. Ikindi kibazo kiri aha kuri biopsy nuko zo iyi ni igira small round cells kimwe na retinoblastoma. So niyo mpamvu immunohistochemistry will help much to distinguish both. And they find that the majority, some affect the parameningeal areas, and the others limbs, orbit, genitourinary, and so on. So you see, rimwe na rimwe umurwayi azaza afite ikibyimba mu zuru n'ijisho ryaraturumutse. So akenshi usanga no mu jisho nta kintu kirimo, ahubwo ni za kanare zizana amarira amanukamo zifunze bigatuma n'ijisho rigira ibibazo, cyangwa se cancer zikaba zarazamutse zaragezeyo, nabyo bibaho tugatubibona. So these things we see, ntabwo ibintu byo mu bitabo gusa we see them. But you see that this chart banamukoreye imaging. You see the mass here around the eye, ariko amaze kuvurwa, you see that she became normal. So novuga this is a curable disease, rhabdomal sarcoma. So fibrosarcoma is a cancer arising from fibroblast. So they are rare, they can occur anywhere in the body, but most commonly in retroperitoneum, thigh, knee, and distal extremities. It is a solitary palpable mass. It can reach 80 centimeters, slow growing, and some of them they present with pain. So ikunda gufata hari iyo kwita adult type ifata abantu hagati y'imyaka 55 akaba nifata abana batoya. So males are more affected. So usually it has no capsule. Nicyo kiranga benign malignant tumors from with usually they have no capsule. It infiltrates, usually causing hemorrhage when it infiltrates and it destroys the blood vessel, especially usually the veins. It becomes hemorrhagic. Then there will be necrosis. So kuri histology rero twe icyo tureba niyo tubonye icyo twita herringbone pattern. So herringbone ubundi ni ifi yitwa ko ari nayo ishushanyije aha. Ni ukuvuga uburyo tugaragara n'ibiki byose biteye ni kubona architecture y'amaserire nayo inabita yo mpamvu bahise gutyo. Peripheral nerve sheath tumor ntabwo tuzivugaho cyane ariko ni nyinshi, harimo neurofibroma. Murabyibuka nabivuzeho ko iyo tubonye neurofibroma yitwa plexiform muri histology biba bisobanura ko umurwayi afite neurofibromatosis type 1, si familial syndrome. So iyo nayo ishobora guhindukamo atypical neurofibroma, then at the end igahindukamo malignant peripheral nerve sheath tumor, MPNST, malignant peripheral nerve sheath tumor. So these are very common in our settings. So turazibona kenshi, but it is as if we diagnose them by exclusion. So we must exclude other soft tissue tumors. Then we do markers which show they have a neuro component. Then we confirm it is. And you see the mutations which happen, especially NF1 mutation and the CDKN2A loss. Most common is the schwannoma. Schwannoma arises from nizo zikora myelin sheath in the peripheral nervous system. So these are freely mobile, non-painful region. Nacyo bitandukanye na neurofibroma ibi painful, ariko schwannoma is not painful. It affects all ages, but is more seen between 20 and 50 years of age. Male and females are affected equally. Head and neck, flexural surface of upper and lower extremities are the most affected sites. So here you can see umurwayi afite around the lower back a tumor here, which is necrotic, umukara, ahatukura ni hemorrhagic, so ahari intact na ahari whitish. Ariko ikindi mubona nuko afite utundi tunodira, these are neurofibromas. So this can explain that uyu muntu yari asanga nyine afite ikibazo cya neurofibromatosis. Then in one of his or her neurofibromas havutsemo a malignant peripheral nerve sheath tumor. So gastrointestinal stromal tumor, so it should have been discussed in the gastrointestinal tract pathology, ariko naha nta kibazo no mu bitabo bombi bagenda bayigaruramo. So ni tumor ikomoka kuri selile bita Kajar, interstitial cell of Kajar, mwarabigize muri histology, on the wall of the stomach or intestines. So this cell, when it proliferates, it gives rise to a tumor. So ikibazo kiri rero nuko iyo ukoze endoscopy ntuyibona kubera ko ntabwo iri muri rumen. Muri rumen hagaragaramo carcinomas. Iyi rero ibiri imbere muri wo ntabwo endoscopy ibona, uretse kuba yabona wenda ko hari ikintu kiremereye kiri hafi aho ngaho, ndabize ntabwo yibona. So niyo mpamvu akenshi niyo wakoze endoscopy agakora biopsy, we don't see, we report this is just a normal tissue, we don't see any tumor. So surgery akenshi niyo ituma uyikora diagnosis. So the most common site is the stomach, others are the small bowel and then colon. The size to peritoneum, liver, and the lungs. Refractory to standard systemic chemotherapy. So ikindi kibamo rero muri izi hafi ya zose 90% zigira mutation muri muri gene yitwa c-kit tunayita CD117. So zigira iyi mutation. So abafite iyi mutation rero iyo tubibonye bahabwa imiti, umuti witwa Grivec niwo muti bahabwa, because this c-kit is one of the few tyrosine kinases. So tyrosine kinase pathway yo muri cell signaling kugira ngo yongere ibe nzima, uyu muti ubigira muri Grivec, uyu muti akazi gakomeye hanga. So practically nko kuri sashika mu rwego rwose tubonye afite gist tureba niba afite imitation dukoresha immunohistochemistry, because we don't do molecular testing. So we do immunohistochemistry on using that c-kit antibody. When it becomes positive, then we report this is the gist and it is c-kit positive. Therefore, icyo dushaka kubwira oncologist nuko niba muha Grivec izamufasha akira vuba. So the tumors of uncertain cell origin, ni synovial sarcoma nayivuze kare, byiswe gutya ko byakekwaga ko iva muri synovium, but it was seen that only less than 10% of the tumors arise from the joint. So this tumor is usually biphasic. So it has a component of sarcoma spindle cells, ariko rimwe na rimwe tubonamo na component ya epithelioid cells, sometimes with glands. So mukabona umuntu afite glands muri bone cyangwa ahandi muri soft tissues, kino zaje zite izite metastasis and so on. But this is the explanation. So it is a biphasic. Here nizo ziri monophasic, usanga ari spindle cells gusa. Otherwise most of them they have both epithelioid and the spindle cells. So as you saw in the list, there are many other tumors of uncertain cell origin, but the most common one is the synovial sarcoma. So we are done with this presentation. So we have 12 minutes to go. Do you have questions? Okay, so it seems no questions. Then I ask mine. Just maybe 2 questions. So an year-old girl from Nyanza district is diagnosed with conventional osteosarcoma. She undergoes neoadjuvant chemotherapy followed by resection. So neoadjuvant chemotherapy cyose hano ni iki nabivuze kuri breast cancer, ni uburyo uvura umurwayi wa kanseri kugira ngo ikibyimba cye kigabanuke, kibe gito, kibe cyabagwa, kibe cyashobora kubagwa. So nicyo yakorewe neoadjuvant chemotherapy followed by resection. So what is considered as a good histologic response to therapy? So kuri histology cyane cyane pathologist niwe azavuga ngo imiti yagize akamaro cyane yakagize muri cases nk'izi no muri breast niko tubigenza muri muzituma zamusona. So muratekereza ko muri izi factors ziri aha ngaha ni iyihe izerekana ko uyu mwana afite good response to the therapy? If 70% of the tumor is necrotized, if 50%, if 90%, any degree of tumor necrosis or only 20% is necrotized. What is the answer?
E.
A. So you can explain why?
For me, I think that if a chemotherapy can reduce a tumor to a very low percentage, this means that it is responding very well on that therapy.
So 20% of necrosis, do you mean you think it is 20% for the tumor, residual tumor? Or because the reduction means necrosis. niba hasigaye 20%, niba nako necrosis yarabaye muri 20%, ni ukuvuga ko 80% of the tumor is still there. Ubwo ntabwo ikibyimba gishonga, ntabwo ikibyimba gishonga ngo kibure, ahubwo aho amasere yapfuye hajya necrosis, nicyo kigaragaza ko imiti yakoze akazi.
If is that the case, answer can be.
Sorry?
If is that the case, I think I can choose C.
Yeah, C should be the answer. You usanze afitemo necrosis nyinshi, uhita uvuga ati imiti yarakoze, yakoze ya the tumor has responded to the therapy. So that's how we do. Kandi nyabwo nawe as a clinician niko uba ugomba kubyumva. So ubwo icyo bisobanura ko utabyumvise neza, yaba niba ari nawe utarabyumvise neza, nuko pathologist nawe bati tumor twasanze almost 100% yarabaye necrotized, uzavuga ngo ni bibi. Aho kubyishimira ahubwo ngo atari bibi. So you must understand these languages. Okay. So the second question, so not the one. So it is the matching. So you just match what is left and the items on the right. So rhabdomyosarcoma, Ewing sarcoma, poorly differentiated synovial sarcoma, Paget disease of bone, and the lipoma. So what is the characteristic of rhabdomyosarcoma in these 5 items? Is it the most common soft tissue tumor in the adults? Does it have a biphasic neoplasm and the cell being of unknown origin? Does it affect the medullary part of the diaphysis in children, meaning a bone tumor? Does it has 3 types, morphological types, embryonal, alveolar, promorphic? So how do you match 1?
One is D.
Is it D? So explain more. No explanation. Okay, so 2.
C for rhabdomyosarcoma, we saw the subtypes.
And what do you remember about it as a subtypes in a prognostic way?
Lecturer, you said that on the rhabdomyosarcoma, these times we saw that they have the cells, when you look at when they are analyzing them, they look like alveolar, when sometimes or for the embryonal and also for the promorphic, you said that they are undifferentiated. I guess it's that.
Yes, and on the prognosis part, so which is having poorer prognosis among the 3?
Promorphic.
Okay, yeah, promorphic has a worse prognosis. So as we saw, embryonal, we have small cells which are round, looking like lymphocytes. Alveolar is not how cells look like. It is a pattern of the cell growth. So uburyo ziba zitenze nibyo bibyara alveolar pattern. Ntabwo seri rimwe ishobora kuva mu ifite alveolar pattern. So promorphic, the cells, they are some are large, some are bizarre with many nuclei and so on. So promorphic meaning. So we saw that embryonal is more common. Ikindi ntavuze nuko nibajye kuvuga nuko twabonye ko ku bakobwa ikunda gufata ni vagina, iyo ishema bayita specifically botryoid type. but right ariko ni shape yayo imeze nk'akantu k'agacuma, na that's why they call it like that, ariko it is a type of embryonal abdominal sarcoma. So ikunda gufata muri hollow cavities, mu kanwa, vagina, in eyeball, mu jisho, bita bisunika ijisho ubwabyo, so bayita botryoid bitewe na shape ifite. So what are the characteristics here of Ewing sarcoma?
E.
E. Explain. So is the Ewing sarcoma a cancer or not?
Ewing sarcoma, it's a type of cancer. I think so. It affects soft tissues.
Yes.
Which
So how can
its complication, it may proceed to osteosarcoma.
Sure. Okay, another person. I think it's so clearly, and we explain more that Paget disease is the one which may complicate into osteosarcoma, because there is a high turnover for osteoblasts and osteoclasts. So Ewing sarcoma, ntabwo habamo cancer imwe izicomplicamo ngo ivemo indi cancer, no, that is not possible. Paget disease being a benign region, it can complicate into a cancer, but cannot say one cancer can complicate into another cancer. So what are the characteristics of Ewing sarcoma here? Of a bone. So here we are in the bone. Okay, we go to 3. Poorly differentiated synovial sarcoma. Characteristics of synovial carcinoma here. Ntekereza ko mutayibagiwe kandi no twaherukije.
I'd say B.
Okay, so it is the cell of origin is not known, and it is usually in the physical way. So having a epiphyseal and a spinocyst. And Paget disease, this we answered, so it complicates into osteosarcoma. Lipoma is the most common soft tissue tumor in adults. So that we saw. So Ewing sarcoma, it affects the medullary part in the diaphysis of long bones in the children. So I think that you remember. So that's all as just the 2 questions I had selected. Do you have any questions? So it is almost noon. So those of you who respond by writing into the chat, as I said, when I'm presenting full screen, I cannot see the chat. Not someone had answered the I with D.
No.
So no question? So we will continue on a Friday, and I think we may finish the most of the 2 chapters which are left of systemic pathology. We are left with hematopoietic cancers and then dermatopathology. And after that, we should see also introduction to forensics. So next week, most likely. So today in afternoon, you concentrate on the assignments. So, and I think you will have to finish the assignments. There will be no other additional time. So on Friday, we'll be very busy with these two